This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 675, recorded on October 23rd, 2020. I'm Vincent Racaniello, and you are listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everybody.
Hello again, Daniel. Another week has gone by.
It has. And
COVID-19 is still with us, apparently.
Oh, things are getting worse, Vincent.
They are.
But I have a lot to say today.
Okay.
So probably jump right in on it. Shall I start with my quotations?
Always. Absolutely.
Okay. I have two quotations today. The best thing about the future is it comes one day at a time. And that was Abraham Lincoln. The second, if we open a quarrel between past and present, we will find that we have lost the future. And that is my favorite, Winston Churchill. And so I guess as we go forward, people can try to figure out what those the relevance of those quotations and what we talk about today. All right, so I'll just start by a thank you, and then I'll get into this. But thank you for everyone that has been going to Parasites Without Borders to help us during the Microbe TV fundraiser. This is going very well, and I'm getting the paper donations. Right, that must the crowd that supports Microbe TV. I'm actually getting snail mail with nice cards and nice letters there. So thank you. Everyone continue to go to parasiteswithoutborders.com and donate to help us get this information out there. We have, as Vincent keeps saying, we have no other source of income, right? This is where it all comes from. All right. The patient updates, I feel a little bad. I've been talking about how long it's been since I had a patient die. And so there's a number of us that are doing, we'll call it pro bono remote guidance for people in other parts of the world. There's actually a nephrologist, a kidney doctor, Dr. Kurapati. He and I talk quite a bit, and we've been emailing, phone, texting, different ways, reaching out to people throughout the world, India in particular, and sort of a tragic story of first one family member got sick, and then this doctor's mom and dad got sick. Mom was sicker than dad. The mom was having a tough time, and then the dad, about week 3, had a sudden heart attack and died. So it's just sort of a tough reminder that this is an unpredictable disease. You thought he was through that tough part, and this sort of reminds me of those early days when the coagulation issues sort of rise at week 3. I mean, the process probably starts during week 2. It probably starts when the whole early inflammatory process starts, but just tragic. In New York, we're having increasing numbers, almost 1,000 people being hospitalized per day, new hospitalizations per day. And speaking to my colleagues in the urgent care centers, I don't know if I shared this before, but the call that we have a lot of people that are sick enough to go to the hospital, but not smart enough. So the actual number of people that are hypoxic, that are having severe COVID, is higher than those numbers that we're seeing. So, okay, news. Again, I try to be positive, so let's take a deep breath. And we're starting to hear about vaccines, how they're going to be distributed. But I just hot off the press today, as we're recording this, Moderna just announced that they have fully enrolled their vaccine study. They've also announced that they have given people the first and the second vaccine. Over 25,000 people, actually over 26,000 people, have already been fully vaccinated. So this is exciting news. We are actually getting people vaccinated, and now we get to wait to see what happens. And we'll talk a little bit about the alternative approach to waiting and seeing what happens. But each state has been asked now to create a distribution plan. And I did talk on Wednesday morning for United Health Group about vaccines. And I touched on this a little bit, but each state has been asked to announce a phased rollout plan for vaccines. We are hoping that by April, we're actually starting to vaccinate in huge numbers. And how do we do this? And this is going to require a lot of cooperation, a lot of coordination, getting that vaccine from production to everyone's arm, I guess. Phase one, this is New York State announced its 5-phase plan. Phase one is going to be healthcare workers in patient care settings, long-term care facility workers, and some long-term care residents are going to be the first to receive the vaccine. Phase two is going to move to first responders, school staff, other public-facing frontline workers, and people whose health conditions put them at extreme risk. I know when I was going through these, I sort of wondered about the first responders and school staff. I feel like as a healthcare provider, we have better access to PPE. So I might have done phase one and phase two a little bit different. I might have, looked at first responders and school staff as sort of a higher priority, but just that's me. We'll see if Andrew Cuomo gives me a call. People over, I don't know if he listens to TWiV, but phase three, people over 65. Phase four, you move to all remaining essential workers, and phase five, you roll out to basically everyone else. Now, I also have some other, I'm going to say that, in my opinion, very positive news. What about these vaccines? Who's going to get them? How much is it going to cost? The federal government is procuring hundreds of millions of doses of what they call safe and effective vaccines. We'll see. I think by the time they're released, they will be, but they've contracted with McKesson for vaccine distribution. And this is the part that I think is great. No American will be charged for either the COVID-19 vaccine or its distribution. So the objective is to ensure that no one desiring vaccination will face an economic barrier to receiving one. So I think that's fantastic. And then we move on to some vaccine news, which is a little more gray. It was announced this week that British scientists plan to infect healthy volunteers with coronavirus in a vaccine challenge trial. So the British experiment is scheduled to begin in January. Volunteers will have a purified laboratory-grown strain of, they use the word live, right? I thought that would also upset you, Vincent, of live, say active virus blown into their noses while they are being quarantined in a biosecurity unit at the Royal Free Hospital in London, where they're going to undergo tests over 2 to 3 weeks after this exposure. So now, what's the argument? Why are they doing this? And so Christopher Chin, he's an Imperial College immunologist, will be one of the lead investigators, is saying that doing it this way, they will be able to tell within 10 weeks how effective a coronavirus vaccine is. And he compares this, says, by contrast, studies that rely on chance exposure rather than deliberate infection can take months and tens of thousands of inoculations to prove efficacy.
Yes, but we're almost done with those, aren't we?
Speed up. I'm hoping we have information before this has to even happen. But okay.
Daniel, they're using young people, so that is the only people you would be able to give these vaccines to, right?
Well, that is the problem with a study like this. You say, oh, well, we're only going to give this, we're only going to do this in young, healthy people because then we feel like that's something we can do. Then you've got to ask the question, does your vaccine work outside of that demographic? And so there's multiple issues with the whole idea of vaccine challenge studies, which I think that we've touched on.
We have. And of course, even though they're young and healthy, these people still die, as you've said before.
Yeah, and we're going to get to that, actually, because that is a little bit of the myth that I want to make sure we talk about today. So the other thing I want to talk about, and this directly ties into this, is when do we start getting that efficacy data? When do we start finding out if the vaccines work? And so there is what we talk about as interim analyses, so triggered interim analyses. And so the different vaccines have already decided when they set up their trials at which point the boards would go ahead and look and see, what is going on. And so we'll do Moderna first. And then we'll do Pfizer second, but in all reality, Pfizer may be coming out with interim analysis first, but that's okay. Moderna has said as soon as 53 infections are seen in their large study group, 30,000 people, right, fully enrolled, they're going to do an interim analysis. They'll do another at 106. Pfizer actually has slated 4 interim analyses, so 32, 62, 92, and 120. And what you do is you basically stop. You say, we'll use Pfizer's example. You have 32 infections, and then they break it down and say what number of those infections were in vaccinated people, what were in non-vaccinated people. And because you're really looking early, you need to have greater than 76% occurring in the non-vaccinated for you to be able to extrapolate that you're above that 50%. You don't stop the trial, but you're starting to get preliminary efficacy data. AstraZeneca has an interim analysis at 75. And I have to say, J&J has a very complicated 4-part requirement for interim analysis. I won't go into that, but basically each different vaccine trial is going to be coming out with interim analysis. We're predicting that we'll be getting the first of these interim analyses in November. So in next month, actually coming up pretty soon.
Well, there's certainly enough cases now to power these trials, right, Daniel?
Yeah, that's the silver lining of every mushroom cloud, right? Is that as the case counts go up, as the infections go up, that means we're going to get our data. This has been an issue with some trials where by the time you get everything ramped up, the numbers are on the way down. That happened in China in a few situations. Yeah, we're not going to have that problem here in the United States. We're ramping up, if anything. Case numbers, testing, schools. The MMWR put out an early release, race, ethnicity, age trends in person who died from COVID-19. And they looked from May through August 2020. And there were a few interesting things here. And I think people should take some time and take a look at this. And a lot of it has to do on how you interpret the data. The data is the data, but how do you interpret it? One of the things you could say is that the majority of the deaths are in people over the age of 65. But 20% of the deaths, 1 in 5 people who have died of COVID, was under the age of 65. The other that I always worry about is a lot of, we live in America where it's a Caucasian predominant ethnic group society. And there's been a lot of press about how this has been hitting, the African-American population, the Latinx, other non-Caucasian populations. And sometimes I worry that creates a sense of, oh, well, it's not our problem, from the dominant ethnic group. But the majority of the people have died. They are Caucasians. It is disproportionately affecting the minority populations, but just to sort of let you know, this isn't that, oh, I'm white, I don't have to worry about this is someone else's problem. The data basically points out that this is affecting everyone. I just sort of want people to get that message here. Just because you're young, just because you're Caucasian, just because you're female, COVID-19 can still potentially kill you. The other, and I guess this was a research letter that came in JAMA, excess deaths from COVID-19 and other causes, where they basically were looking at causes of death during this, it was a period of time, March to July. And they were pointing out, there's going to be 2 articles I want to talk about here, because again, it's an interpretation of the data. Based upon the JAMA article, they suggest that of the excess deaths, 67% of these deaths were due to COVID. And what they're suggesting is that maybe we're not counting all the COVID deaths. The MMR had another excess death article, and it was looking at January 26th to August 3rd, so sort of a slightly broader, basically estimating that there were close to 300,000 excess deaths that were occurring during this period of time. Also hit right about the same number, 66% versus 67 were attributed to COVID-19. But the largest increase in deaths was in the age from 25 to 44. So I think that's, again, sort of, raising a couple questions here. Why are they dying? Are they dying from COVID-19? Are they dying from other reasons? Are they neglecting care? Well, I usually don't think 25 to 44, year olds dying because they didn't see the doctor routinely. Are the lockdowns so bad that everyone's committing suicide? I've seen that in the press. I don't think that is actually consistent with the data. But just really sends the message that we have lost 300,000 more Americans than we normally would have lost in just this 9-month period.
We have 100,000 confirmed deaths from COVID. So some of these are probably COVID that weren't diagnosed, and others are somehow related. Is that the idea?
So we think it's a mix. There is a certain, 2/3 are confirmed COVID related, and as in COVID was why you died. The other are the occurred during this period of time. We don't know specifically that it was due to COVID. It's probably a mix, and we don't know what percent of those were due to COVID.
Got it. Okay.
The other is actually something that's going to become more relevant. So I think we'll probably be returning to this, but it is the question of indoor dining and the upcoming holidays. And the EPA has a web page, actually, Indoor Air and Coronavirus COVID-19. And they have links to lots of resources and some guidance. There's been a little bit of press about this lately. The CDC has updated some of its guidance. Make sure we touch on that. But just to reinforce what we know relative to this issue, the principal mode by which people are infected with SARS-CoV-2, the virus that causes COVID-19, is through exposure to respiratory droplets carrying infectious virus. Now, what about the term airborne transmission? It's a hot wedge issue, right? COVID-19 and how this applies to indoor environments. So the CDC recently updated its website to clarify this point, and I'm going to go through and point out several things. So the term airborne transmission, as some of our listeners know, but not necessarily all of them, has a specialized meaning in public health practice, and the CDC points this out. So I'm going to quote the title of a piece by the journalist Roxanne Kamsi. She's a Wired contributor. They say coronavirus isn't airborne, but it's definitely borne by the air. So what is all this confusion and controversy, and how did this become such an emotional hot button or wedge issue? So it really goes back to this specialized meaning that the CDC is trying to explain. So the CDC web page points out that diseases such as tuberculosis, measles, and chickenpox are efficiently spread by smaller droplets and particles that can remain suspended in the air over long distances, usually greater than 6 feet, and time, typically hours. So now I'm going to actually quote the CDC. So open quote, the epidemiology of SARS-CoV-2 indicates that most infections are spread through close contact, not airborne transmission. So now that they mentioned airborne transmission, there was sort of all these people, very excited. But just to point this out, they are saying that this is not the dominant spread. Pathogens that are mainly transmitted through close contact can sometimes also be spread via airborne transmission under special circumstances. And then they go on to point out that there are several well-documented examples where it looks like this may have happened, but they then say these transmissions appear uncommon and typically involve the presence of an infectious person producing respiratory droplets for an extended period of time in an enclosed space. So that leads us to indoor for the holidays, because what are we actually talking about doing? Well, they go on to say enclosed spaces within which an infectious person either expose susceptible people at the same time, or to which susceptible people are exposed shortly after the infectious person had left the room. They talk about prolonged exposure to respiratory particles, and they talk about inadequate ventilation or air handling. So where are these indoor dining opportunities available? So one is in our homes. Most of us do not have advanced ventilatory systems. Most of us, perhaps Vincent has a large palatial dwelling, most of us do not have huge spaces. So we actually, when we come indoors to dine together, we're actually in pretty close contact for a prolonged period of time, performing respiratory particle producing activities such as speaking. We don't sing in my home. Well, actually, I have some teenage daughters. They do actually break out in song without being provoked. And so there is the concern, and actually epidemiologically, what we're seeing is most of the transmission that's occurring right now is actually in the indoor home setting. A lot of restaurants, because they're trying to do the outdoor dining, have created these closed bubbles with no ventilation systems. And I like to point out that you have just created an indoor space. Just the fact that those walls are made out of plastic, that is not great. And usually those enclosed areas do not have great ventilation or air handling. So what are the current recommendations? And a lot of physicians are being asked these questions. So I'm going to give 9 recommendations. So 1, if possible, stay outdoors. We estimate that this is 20 times safer than indoors. Distance. Stay 6 feet apart. Much easier to do this outdoors. Time. And this was actually something that was added to the CDC. We say if you're within 6 feet for 15 minutes or longer, it doesn't have to be continuous. You can't walk away for a minute and then come back for another 14. It's not like you set your clock. If you're there for 14 and you leave and you come back for 2, you're now at 16. So exposure is cumulative, and that was updated. Actually made it the front page, I think, of the Times. So masks. Masks catch your respiratory droplets, the large ones, the small ones. And I do want to point out, you have 3 holes in your face through which you breathe. So unless you're a strict mouth breather, you got to cover your nostrils. If your mask is too small, go get yourself a big boy mask. Now, I'm not sure why this is such a male thing, but it tends to be the men that are walking around with their nostrils sticking out. So if you're exhaling through your nostrils, you got to cover them. Otherwise, the mask isn't doing much. Ventilation, open the doors. This is like the Jimmy Carter days, right? Remember when he told you to just put on a sweater, open the windows, put on a sweater. Let's try to improve the ventilation. I remember my cross-country running coach back in high school, Twiggs Myers. He used to say, Daniel, when I want to enjoy the outdoors, I crack a window, and when I'm done, I shut it. Keep the windows cracked. Wash your hands, not just for employees. Get tested, particularly if you're thinking about getting together with vulnerable people during the holidays, not just one test. Try to get a couple tests because each test has a certain miss, a certain sensitivity. So if you can get a couple tests right before the holidays, this is going to help. Nothing is foolproof. And number 9, consider a Zoom holiday party. We actually did this with some of the past holidays where older friends and families, they're having a tough time with all the social isolation. So we actually set up the computer and they had set up an iPad. And I think by now everyone's getting a little savvier, but it allowed them to be sort of part of the conversation and to participate. So that is my comments on indoor dining.
Can I make a comment on the CDC description that you gave us?
Yes, please.
I find this terribly confusing. Okay, here's how I look at it. Most SARS-CoV-2 transmission is through the air. It's either droplets, which are close within 6 feet, or aerosols, which can go a long distance. This close contact implies contact, but what they really mean is within 6 feet, right?
That is exactly. We've got to just scrap the English language and come up with something that's,
I mean, it's all airborne.
We use the same words for too many different things. So yes, It is transmitted through the air and dominantly within that 6-foot zone. Yeah. Stop spraying all your groceries with, bleach. It's really, it's the coughing, the sneezing, the breathing, all that stuff. Some treatment drug updates. Unfortunately, this is lots of negative data here, so I'm just going to sort of march through this. We now have the results of the WHO Solidarity trial, which was the repurposed antiviral drugs for COVID-19. They looked at over 400 hospitals, 30 countries, over 11,000 adults. They looked at a whole bunch of stuff. I'm just going to cut to the chase. Remdesivir, hydroxychloroquine, lopinavir, and the interferon regimens appeared to have little or no effect on COVID-19 as far as mortality, ending up on a ventilator, duration of hospital stay. So the mortality findings are not very exciting. So I do want to say something positive right after that. So just a reminder that prone positioning does appear to be beneficial. And back in June, there was the article, Prone Positioning in Severe Acute Respiratory Distress Syndrome, published in the New England Journal of Medicine. And this actually was encouraging. But I just want to bring up that you have to be careful when you do something. So this study back from the New England Journal showed that the 90-day mortality was 23.6% in the prone group versus 41% in the supine group. So that was a hazard ratio of 0.44. So that was encouraging. But you have to be careful when you prone position patients. And there was just a paper, Improved Prone Positioning for Severe ARDS During the COVID-19 Pandemic, an implementation mapping approach. And basically outlining how do you do this successfully. Basically, you got to educate people. It's ideal to have a proning team. And I just sort of want to bring this up because we had a patient that was recently seen by one of my neurology colleagues who was proned improperly at, we call it an OSH, an outside hospital. And they actually ended up with a brachial plexus injury. Somehow when they took this large gentleman and turned him over to be proned, they ended up ripping the brachial plexus out. And so came right out at the roots, and now the person can't feel or move that arm. So, proning is important to do, but make sure you do it right. Organize a team, think it through. Okay. Next thing I want to hit on, and this is actually really important. I don't know if it seems important to people when they think about it, but the issue of unnecessary antibiotics being used in COVID-19. So only 10% or less of patients with COVID-19 have a bacterial infection at initial presentation, yet the majority end up receiving antibiotics. So there was a nice article confronting antimicrobial resistance beyond the COVID-19 pandemic and the 2020 US election. Sort of interesting tale to that title. It was in Lancet, which I'm not sure why the Brits are so concerned about our election. But it was outlining this issue with inappropriate antibiotic prescribing during the pandemic, and actually raising concern that we're gonna follow this pandemic with an antimicrobial resistance pandemic, where we're no longer able to treat common bacterial infections, a simple cut, someone going for surgery, because we'll have bred such degrees of antimicrobial resistance. So, we risk returning to the dark times before antibiotics. So a lot of this is directed at ER physicians, right? Not everyone with COVID needs that first dose of antibiotics just to be safe. Urgent care doctors, let's stop giving out all that Augmentin and Zithromax. Primary care doctors, you're going to want those antibiotics for other things after COVID-19, but patients too. When your doctor offers you an antibiotic to treat a virus, think it through, have a dialogue. Sometimes they think they're going to improve patient satisfaction. So this is a viral disease. Let's stop using those antibiotics. A study that was available as a pre-proof, accepted to gastroenterology, is sort of negative stuff about famotidine. And the title says it all. Famotidine use is not associated with 30-day mortality. A coarsened exact match study in 7,158 hospitalized COVID-19 patients from a large healthcare system. And basically the post-match 30-day mortality was 15.1% in people that got famotidine and 9.5% in non-famotidine users. So, the biggest impact was people came in, they had never seen famotidine before. You gave it to them or not. Giving it to them did not improve outcomes. And I think people can look at those numbers and say it looks like it may have done the opposite. We did learn a little bit more, and this is something I know for months now, my colleagues and I have been really just struggling to understand. Patients early on with COVID-19, early on from the ICU perspective, have their lungs start to fill with this thick jelly-like liquid. It's almost like they're drowning. And we didn't really know what is this stuff. And in the Journal of Biological Chemistry, there was an article where they actually identified this substance as hyaluron in the lung alveoli in severe COVID-19. Now, what is this stuff? Hyaluron is an important component of all the extracellular matrices. Its levels tend to go up in response to inflammation and injury. It's an odd molecule. It's it basically absorbs water incredibly well. It's a fancy word for that I'm not going to use. Hydroscopic. And it can actually absorb up to 1,000 times its molecular weight in water. And so basically people's lungs are filling with this highly viscous material. And so now that there's been this identification, there's actually a hope that this might open some treatment options. So that's encouraging. We talked about vaccines, and so encouraging stuff there. And now we're getting to the tail. We're almost done. And here at the tail, I'm going to discuss the tail of COVID-19. There was a recent themed review for the National Institute for Health Research, suggested that we use the term ongoing COVID, but then they kept calling it long COVID after they suggested that as a term. So I found that a little bit interesting. But it's becoming more and more appreciated that people don't necessarily just get over COVID. Please stop telling your patients to just get over COVID, because some people are suffering. And I think just to sort of put this in human terms, just this week, Melania Trump, the current president's wife, decided, I don't know if that's current president or current wife, but both, decided not to attend a rally because she actually was saying that she's still not fully recovered from COVID. She's having body aches, a cough, headaches, feeling extreme fatigue. Right now the media attention was focused on the upcoming election, but here's a mom, a wife, her husband gets sick, goes to the hospital, she gets diagnosed, her son finds out he's infected. I think it just reinforces that there's a lot of people that don't just get over COVID and continue to have suffering for weeks, and as we now know, months in some cases. So thank you so much, and turn it back to you, Vincent.
I wondered what you thought of this paper published in Nature Medicine, where a group at Mount Sinai looked at cytokines in COVID patients, and they decide that IL-6 and TNF-alpha should be considered in the management and treatment of patients. What do you think?
So do they want to give the IL-6?
No, those are elevated, in hospitalized patients.
Yeah, it is interesting. Maybe we'll get to this actually we'll probably discuss this in the next one. I've been working with about 30 co-authors from around the world to try to put together a phases of COVID consensus. And I'm actually almost there. Actually, I'm just dreading trying to submit it and enter in the 30 authors. I tried to get one of the other co-authors to do the data entry on all the authors that you have to do. But there is this period, this early inflammatory period, which is when people have the pulmonary decompensation, when we now realize that the coagulation process starts, doesn't become clinically apparent until week 3, but it looks like it starts during that week. We see increases in IL-6 and other inflammatory markers, which got it coined as the cytokine storm. So I think a lot of, and actually the thought behind this consensus is that the different therapies need to be timed appropriately. So you time your antivirals during that, really probably start it during that incubation phase, if possible, if you can identify. You definitely want to start it as soon as you can when you get detectable virus. But then during that second week, when the virus is on the way down and IL-6 and the other cytokines and inflammatory markers are going up, that's when I think it makes a lot of sense to start looking at therapies then.
Yeah, I ask because TNF-alpha, I haven't heard much. I've heard IL-6, elevated in COVID, but this week on Immune, we did a paper which suggests that, in patients with serious COVID, the germinal centers of lymph nodes and spleens are trashed, and that's why you don't make good antibodies. And they think it's associated with TNF-alpha, and even suggests that, blockade might be beneficial.
Yeah, and we have drugs. We have drugs sitting on the shelves. This is a target that we can look at, and we can actually we can start doing those trials.
I have a question from Rich Conda and Grant McFadden, 2 pox virologists. Reuters reported that a participant in the AstraZeneca trial has died of COVID, but that the trial is not being paused. I think they didn't die of COVID, but they died. The implication is that the death is in the placebo arm. Further, the implication is that someone monitoring the trial knows who is placebo and who is experimental. It seems someone must know the code to decide How does this work? Is there, in fact, a person that knows the code but is insured to keep the trial otherwise blind?
Yes. So there are these data safety monitoring boards, and I actually know several people that are on these boards for the vaccine trials. And when something like this happens, actually when something like this has happened in trials where I was the PI, this person would then do this investigation and they would find out. Because you do want to know when someone has a bad outcome, is this someone who got the vaccine or not? If someone had gotten the vaccine and died, that definitely has different implications. But they look specifically at just this one person. There's a certain code that identifies who they are. They can then break the code. This is all recorded. But yeah, so there are data safety monitoring people. Whenever there's a serious adverse event, they will look at it and try to determine this.
DSMBs. Yep, very important. All right. Tom writes about a sad story of a young man in his 20s who had developed flu-like symptoms on October 3rd and died on October 18th. He was not tested for SARS-CoV-2, but the doctors implied that a leukemia-like illness was occurring. And the question from Tom is, are you aware of SARS-CoV-2 triggering a leukemia-like signs? Could it accelerate leukemia?
So I'm going to say no. I am not familiar with that. I'll say no to that. I want to be specifically when I say no. So there are a number of viruses that trigger these atypical reactive lymphocytes, and examples of those would be Epstein-Barr virus, cytomegalovirus, several others. So we sort of have a differential for things that trigger this leukemia-like crisis. This is not something we have seen at any significant amount in COVID-19, right? And we've seen millions of cases now, right? And a lot of the clinicians I work with have seen hundreds, if not thousands now. So this is not a classic COVID-19 manifestation.
And then he asks about funeral preparations, which we have touched on before, Daniel. And he says, people want to do this because people expect attendance, but it's a great way to transmit infection. And so he's saying, you have an audience of clinicians and regular people looking for real information. Please provide science-based opinions about how they should behave in terms of a funeral.
Yeah, no, this is really tough. So I'm going to sort of reach out to the listeners, but also our clinicians as well as non-clinicians. We've actually related some stories firsthand here, where funerals are a place where the virus seems to be spread. We had that woman and her husband. His sister died right in Boston. The body was brought down for a wake, followed by a funeral. And people at a situation like this, they're emotional. They're touching their face, they're crying, they're gathering together. It's very hard not to comfort a loved one who's going through this. They may have the virus. You may have the virus. Someone else may have the virus. You get into these situations. They're indoors, right? Not a lot of us do the wakes outdoors. These rituals involve basically the potential for significant spreading. Hopefully people have started to get the sense that early on there was the idea that there were certain individuals who were super spreaders, but usually it's a situation that creates the super spreading. So you get a lot of people indoors within that 6 feet, that magical 6 feet for more than 15 minutes, cumulative, and you have potential to turn, one horrific loss into multiple horrific losses. So, start trying to think about ways to do this differently. I remember stories from, the Ebola outbreak, where you really just sort of sat down with people and said, let's talk about ways to modify our rituals so that they accomplish what they need to accomplish, but without putting everyone at risk. So this is a situation where let's take a deep breath and try to prevent these super spreading events.
And Tom says, I understand Dr. Griffin has written a stages of COVID-19 summary. Maybe this should be mailed to every doctor treating patients as a public service.
It's going to very soon. It's going to be hopefully in the next couple days. We're going to get everyone to sign off on the consensus, and we'll get it submitted.
Great. It'll be a preprint put up that we can share. Is that right?
Yeah, I'm sort of accepting the whole preprint world.
Okay.
So.
All right, one more email from Mona. I have a question for Dr. Griffin. You say there's a growing problem with school reopenings and more new infections. How do you think this can square with the upsetting data from the American Academy of Pediatrics and Children's Hospital Association that show the COVID cases in children have been rising steadily since April without a jump in August or September? Gatherings such as birthday parties, which have resulted in cases you've told us about, aren't necessarily related to school reopenings. And Mona provides links to several of these reports from these academies and also CDC. And she concludes, we need our children to be able to go to school. So the increase is alarming. Over 300% more cases in children since April. Perhaps it has more to do with testing, but according to the pediatrics article, CDC data from public and commercial labs show the share of all tests administered to children ages 0 to 17 has remained at 5 to 7% since late April. What do you think, Daniel?
So, Mona, I appreciate you writing this email because, I always want to try to be clear, with the school openings, right? So it was a number of months back, I was giving advice to a Montessori school about, potential ways to open safely. And at one point they offered, what is your hourly rate, Dr. Griffin? And I said, well, you can't pay me because it's a conflict of interest. And they said, what are you talking about? And I said, I really think it's important that we shoot for students getting back to school in person as a goal. And if I'm getting paid to make that happen, then I'm going to feel like there's a certain conflict of interest. They seem very confused, I guess. But my goal, and I think the goal that was stated by the American Academy of Pediatrics, is that the goal is to get K through 12 kids, particularly in school, in person. But this has to be done, I think, safely. What I do want to point out, and I think this is really positive, is that what we have not seen is large spreading in most of our public schools. It does not appear to be spread occurring within the walls. The other thing I want to say, and I think this is what we're seeing here in the data, is we are seeing that spread occur outside the walls of the schools. We're seeing it occur at gatherings such as birthday parties and the rest. And this has been gradually rising. And as you point out, and this sort of, don't want to be blamey of the schools, it's not like when kids went back to school, suddenly the birthday party incidences increased dramatically, but they have continued to increase. And what we've observed in the area here is we're seeing larger birthday parties now. Instead of just the close friends, it's the entire school class. So, as we're seeing the numbers rise in our local area, as we're observing, who the positive cases are in this population, the schools, I think, are doing a really good job with masking, with distancing, with ventilation. Actually, I have a good friend, Scott Burson, who's down on the South Shore and is a principal at one of, I think, the Baldwin schools. They have not closed at all. They've done a really good job of, half the school goes in the morning, half the school goes in the afternoon, reducing the numbers so they can accomplish all the spacing and distancing and everything they need. But yeah, the numbers are gradually going up. It would be ideal if there was testing, some other ways to sort of help this population. But no, we are seeing the numbers go up. And as we pointed out, this is a population, though, at low risk. They're not at no risk.
And here in New York City, they've done pretty well, minimal numbers of cases detected. But the point is, and you've mentioned this, you have to space out the students. You have to take measures. You just can't send them back the old way to school, right?
Yeah, you have to do it differently. But I really still am a believer that it can be done safely if you have the will and you're willing to spend the time, effort, and money to make it happen.
Right. All right, that's our weekly COVID-19 report with Dr. Daniel Griffin. Thank you, Daniel, again.
Oh, thank you so much. And everyone be safe. And again, thank you so much for everyone who's gone to parasiteswithoutborders.com to help us with our fundraising drive to support Microbe TV.
Joining me today from Fort Lee, New Jersey, Dixon Despommier.
Hello there, Vincent. It's a gorgeous afternoon after a really grotty morning. It's kind of humid. It doesn't feel like fall yet, but if I look out my window, I see a lot of pretty trees. So I think it's a great time of the year.
So, Dixon,
Yes. Excuse me for interrupting, Vincent, but
we're just having a pre-show about using so and
That's right.
Also joining us from Madison, New Jersey, Brianne Barker.
Hi, it's great to be here. It is 69 degrees Fahrenheit, and the grotty weather, as Dixon called it, has not yet left here. So it is still overcast and gray and also humid.
Yeah.
Also joining us from Western Massachusetts, Alan Dove.
Good to be here. And it's pretty similar here, 66 Fahrenheit, 19 C. I think we have some grouty weather in the bathroom.
Yeah, grouty. Alan, our guest last Wednesday, I asked her where she was from, and she said Western Massachusetts.
Oh.
I forgot what town she's from. That was Lisa Grolinsky. She grew up in Western MA. Her parents are still living there.
Okay. A lot of people's parents are still living in Western Massachusetts. That's the thing.
Thank goodness.
Also joining us from Austin, Texas, Rich Condit.
82 degrees. Hi, everybody. 82 degrees. I think we're maxed out for the day. And, I keep talking about how fall is arriving, and it keeps sort of dragging its heels. Mm-hmm. But 82, kind of muggy, cloudy. It's okay. Yeah, I can handle it.
Do the leaves all fall in Austin?
Yeah, they don't bother to turn colors, though. They just hang on for a while and then just die.
You have a lot of cottonwood down there, though. Those are pretty in the fall.
Yeah, I mean, there's a few trees that are, okay, but most of them are pretty lame. I'm used to it. Florida was the same way.
Yeah, that's true.
We're just passing peak foliage here. It was gorgeous, and now it's kind of all going brown.
Yeah, exactly.
Alan,
I just mowed a bunch of maple leaves on the lawn today.
Alan, you know how people nail signs to telephone poles, advertising stuff,
yeah.
Right? So I passed one the other day, stump grinding with a phone number. I almost took a picture of it for the show. That's a very common telephone pole sign, stump grinding. I mean,
yeah, I've seen that. And there was one a few years ago after we had a bad ice storm that came through, dropped trees all over the place, and somebody had a handmade sign that they'd put up on a telephone pole that just said "Man with chainsaw." That's good.
That's good.
And I couldn't decide if
hiding
that was
in your garage
or a warning or a cry for help.
That's right.
Whoa.
Answers to the name Freddie.
Maybe I should put up a sign, virologist with a phone number.
Virologist, yeah.
Oh,
With a virologist with a pipette.
A virologist with a pipette. Yeah, that would be great.
how about Vincent and the Pipettes?
That's a good name for a rock
Start
group.
a singing group.
Yeah.
Yeah.
I always liked, and Brianne will like this one, C1Q in the Collectins.
Ooh, I do like that.
So there's a chapter in our virology book. In one of the immunology chapters, there's a section called C1Q in the Collectins. And I guess that's a complement protein that binds certain patterns. And I always thought that's a perfect name for a rock group, right?
Yeah.
C1Q in the Collectins.
When I was on my sabbatical in Australia, I had created a small quartet, and we called ourselves the Tandem Repeats. And it was a lot of fun. We had a lot of fun with that.
My wife played
Playing
softball.
the same song again and again.
Again, but you played it backwards half the time.
This is true. We changed our name to the telomeres. It didn't help.
It didn't put an end to it. Okay.
Here's another good
It
one.
didn't put an end to it. Exactly.
I like it.
My wife played softball at Merck, and their team was called the 4 Base Cutters.
Good.
Nice.
Good.
Come on, guys, you gotta love that. That's so nerdy.
Yes, it is.
What's the name of the herpes rock band that plays at the ASV meetings?
Herpetic
never go
Legion.
away.
Herpetic Legion.
Herpetic Legion.
Okay.
And I made a video of them at a ASV, was it? No.
Yeah.
Was it an ASV?
I think it was an ASV.
Yeah, I recorded them and it's up on YouTube, Herpetic Legion. And someone wrote in, they suck. The guitarist is not bad, but the vocals are horrible. Yeah, they're a little off key. They don't practice very much, you know.
But
Yeah,
they're
like
persistent.
Sure.
once a year.
They're persistent.
They keep coming back
coming
out,
back.
especially under stress.
No, I actually they did some good songs, and it was a lot of fun. Herpetic Legion. I'll put a link to that in the show notes. Let me make a note here.
Everybody just needs to lighten up.
Yes.
Okay. We're all just here to have a good time. Okay.
People
got
do
that
need to
right.
lighten up and be nice to each other. Although
Indeed.
I was trying to think today if I ever lived in a time when everyone was always nice, and I can remember people not being nice when I was a kid. So it's nothing new, but it seems to be worse now.
That doesn't mean we shouldn't be nice now.
No.
I mean,
We have bigger amplifiers now.
I was going to say, we got a lot of social media that you can check out. It's got tons of crap.
Yeah, we do have bigger amplifiers. That's a good
But
point.
we're nice.
Vincent, I think you're muted. Oh,
You think I'm muted? Really?
no, you're back.
your lips were moving, but I couldn't hear anything.
Oh, it happens a lot. Happens a lot. All right. And you know, it's a cool Zoom trick. If you're in a big meeting and you just mute yourself, but if you want to talk, you just hit the space bar and you unmute
Right.
temporarily.
Yeah.
That's very useful. Okay. Throughout the months of October and November, all donations made to Parasites Without Borders will be matched and doubled by PWB and donated to Microbe TV. Thank you, Parasites Without Borders. So go over to them, parasiteswithoutborders.com, if you'd like to make a donation. We still have a couple of job openings. Lab technician with Amy Rosenfeld to work on plus-strand RNA viruses that lead to respiratory and neurological diseases. Applicants should have a BS in science, some lab experience that is not a laboratory class. You can email tech@microbe.tv. And the Biological Safety Program at Columbia has an opening for a biological safety officer. In the age of COVID-19, biological safety professionals have never been more needed, valued, or felt more purpose in their calling. The ideal candidate would be someone with a life sciences degree, bachelor's or higher, at least 2 years of lab experience, who is hungry to learn about infectious agents and molecular biology. More information and application instructions are available on the Careers at Columbia website, and we'll put a link to that in the show notes. I happen to know that the Director of Environmental Health and Safety here at Columbia, under which this program is located, she listens to TWiV. And she was amused by our discussion of biological safety, especially mine when I said there was no biological safety when I was a PhD student. Sometimes I'd like to get you on, Casey, and talk about biological safety in a modern era. That would be fun.
Yeah, that would
Would
be
you
good.
like to do that, Casey? Let us know. All right, a couple of things before we get to email. The first came to me early this morning, and I guess it's real, but it's a letter from Bill Foege to Robert Redfield. Now, Bill Foege is a very well-known and respected physician and epidemiologist. He was the head of the CDC. Carter, Reagan, and who was
I think
that?
just Carter and Reagan,
Carter and
77
Reagan.
to 83.
Yeah, Vincent, do you mind if I correct your pronunciation of his name? I know this guy, Bill Foege. is the way
Foege,
he
yes,
pronounces
you're
it.
right. Sorry, Foege.
That's right.
But
He might be old, but he's still Foege.
Still fake.
so this is a highly respected guy who did
Absolutely.
very well, and he writes Redfield a letter. And I think this seems to be, so the link I will give you is this document that's all pasted together, but newspapers are all saying that this was revealed by USA Today.
Yeah, and NPR has an interview with him, and they say that it's correct. So they obviously people have had a chance to fact check this. I don't think it's fakey.
You don't think it's Foege?
I don't think it's fakey.
Oh, Foege, but it is
I think it's
Foege.
by Foege.
Okay. Well, basically, it's Dear Bob. These guys know each other, and
Yeah.
he says, you need to face the truth. You and I both know that despite the White House spin, this will go down as a colossal failure of the public health system in this country, the biggest challenge in a century, and we let the country down. The public health techs of the future will use this as a lesson on how not to handle an infectious disease pandemic. Wow, that's pretty serious business.
That's
there.
very, very serious.
The cause will be the incompetence and illogic of the White House program. The White House had no hesitation to blame and disgrace CDC, you and state governors. They will blame you for the disaster. In 6 months, they have caused CDC to go from gold to tarnished brass.
Wow.
And he goes on to talk about what has happened and what we should have done. One of them is the absolute need to form and guide coalitions has been ignored as the president thrives instead on causing divisions. And listen to this. Fifth, we have learned the best decisions are based on the best science, while the best results are based on the best management. The White House has rejected both science and good management. To depend on someone like Dr. Atlas, who doesn't understand herd immunity, is simply one of multiple examples. So he says, basically, you shouldn't resign because that'll be a one-day thing and then everyone will forget you. But what you should do is write a letter to all the CDC employees and acknowledge the tragedy of responding poorly, apologize for what has happened and your role in acquiescing, set a course for how CDC should lead the country if there was no political interference and so forth. And apparently, he said, I'm on several round-robin email chains with ex-CDC employees, and they feel the same way. He said, you'll be fired, but that will be more dramatic than you quitting. And then he ends, I don't for 1 minute relish your position, but FDA or NIH cannot make a statement that changes the course of this epidemic. You and CDC could. So I think this is very powerful. Now, if you read Bill Foege's Wikipedia page,
Foege's
Wikipedia page, Racaniello, I know how it is. He's a very well accomplished person.
You're mute.
Your sound's
Vincent.
off again.
No, it's not.
Now you're on.
I'm not doing anything. How can it be off? All the connections are on.
Yeah, my recollection with him from the American Society for Tropical Medicine and Hygiene is that he's a very conservative, gentle, thoughtful person, and he doesn't make rash statements ever. And this is an extraordinary letter to be coming from his hand, because he's been in this field forever, and he knows the ins and outs of everything. And he's not a sensationalist. He doesn't jump on facts and raise his hand and scream and yell and jump. But this is really, that's a call to arms, basically.
Of course, he will be accused of being political. But he did work in the Reagan administration, right?
Yeah, he worked for a Democrat and then a Republican. And this guy is on the side of public health.
He is, period. That's exactly right. It knows no party line.
Which is actually true of most people in public health when you talk to them.
No, you're right.
Yeah.
But they got into it.
So I thought that was worth mentioning.
Yeah. It is. Thank you.
I agree. I wonder what kind of outcome there is going to be, or if we're going to see any changes because of it.
Well,
not until January
2nd. Is the earliest. Yeah.
If
everything goes,
If I
That's
were,
right. Yeah, let's not go there.
Not jinx
Please,
that.
I don't want to.
If I were Redfield, I would do this. I think it's good advice.
That's right. That's right.
He's going to get fired. Does he really care? I mean, I'm sure he's not paid a lot. I'm sure if he were a professor at Hopkins, he'd be paid more.
I'm sure he can get another job elsewhere and land on his feet. That shouldn't be the issue. And, if you go into a public role like that or a public policy role like that, and you're not willing to stand hard enough on your principles to be fired, then you shouldn't be in a public policy role at all.
Here. Yeah, I agree.
We'll see. I don't think anything will happen, but we'll see.
No, I don't think anything will happen, but
I mean, just one more person leaving the administration at any level is not going to raise eyebrows anymore.
This would raise eyebrows because he's the director of the CDC, and for Trump to fire him at this point would be pretty spectacular. It is correct to say that it would be big news.
Well, I would hope you're right.
It would be bigger news than him resigning.
Well, I think he should write this letter that Foege, right?
That Foege, yes.
Foege
Foege recommends.
I think the president said recently that he wanted to fire Fauci, but
yes,
there would be too much outcry, right? Didn't he say that?
Yeah.
You didn't want to panic America, so you left him in his job.
Yeah, a little late for that.
Another item I wanted to bring to your attention is an article or an opinion, a news feature in Nature called "The False Promise of Herd Immunity for COVID-19." And this is subtitled, "Why Proposals to Largely Let the Virus Run Its Course, Embraced by the Trump Administration and Others, Could Bring Untold Death and Suffering." And it's a very nice summary of how this has gone by. And I just want to take a few minutes to address it. So they start out with talking about the Brazilian experience, where they had a huge outbreak of SARS-CoV-2, overwhelmed the hospitals. Lots of people died. And this is back in June. And then it slowed down in September, and people said, oh, we must have acquired herd immunity. And so they did some serological surveys and found 66% seropositive rates. And so this kind of gave other people a little bit of ammunition, say, hey, we should do the same. We should let the virus rip through our population and give us herd immunity. So and then the article gets into what is exactly herd immunity. And I wanted to actually define it again. We've talked about it a lot, but there's a number of quotes here by Christian Anderson, an immunologist at Scripps, who says, surrendering to the virus is not a defensible plan. We have never been able to do it before, and it will lead to unacceptable and unnecessary death and suffering. And
this is a really important point, that we've never wiped out a virus by letting it run its course. That just, and if you think about it evolutionarily, any virus that would burn out naturally, just that's doomed. And so it's not too surprising that smallpox and polio and measles and mumps and rubella and the list goes on and on and on, that we now prevent with vaccines, and we can control those. We eradicated smallpox. We could eradicate the other viruses on that list if we really, got it in gear. But the only way to do that is with vaccines. Pre-vaccine.
Yeah, that's right.
They just kept going and going and going, and everybody would get smallpox in a population. I mean, it's incredibly transmissible, and the people who got it, they would have lifelong immunity against it. It's got everything going for it for herd immunity, but it didn't go away.
Right. And I think the other point to think of is that you think about those viruses, and I'm thinking smallpox in particular, but you could imagine any of the ones Alan mentioned. How long were they around? How many years were there? And we didn't achieve herd immunity. So I'm not sure why we think this is going to happen, within a year or so.
It's fantasy. It's wishful thinking. It's and I will admit, very, very early on, when the first outbreak was happening in Wuhan and they were doing all these lockdowns and they finally got things under control, I brought up the possibility, well, okay, it could be that something in the, the distancing and everything worked out. And at that point, we really didn't know how contagious the virus was. It also could be that it was just never going to get a foothold, or it could be that it's just so transmissible and widespread that everybody in the city's immune now, which was a possibility at that time. We now know that that's preposterous. That's not what happened. Yeah. What worked was people staying home and keeping their distance and wearing their masks and, all that stuff that got done. And that's the only way to control this until we have a vaccine.
Yeah,
so is Sweden? I'm sorry, I interrupted you, Brianne. Please go ahead.
I was just going to point out that when immunologists sometimes talk about herd immunity, the example they give is with the measles on the Faroe Islands. And one of the key things there is that we're talking about a small population that's completely isolated from everyone else, which is not at all what happens with the COVID-19 situation. Yeah. And so while, yes, I talk about that example in my classes, that is not something I expect to happen in life now.
And with measles, critically, the infection confers lifelong sterilizing immunity in most of the people who get it. And so you get measles, and if you get over it or, whatever, you have complications or you die or you're done. you're done with measles. And if you're in some place like the Faroe Islands, where it's completely contained, it's a small population, the birth rate is low enough that you don't have it. This is another important item, that you don't have a continuous introduction of susceptibles, then yeah, it can burn out.
The Faroe Islands is a great example of immune memory.
Yes.
And that's what we use it to illustrate, not herd immunity, because as you say, it's just a tiny isolated population and hardly anyone went to it.
Right.
It's true. So is Sweden going to become our control?
Well, we're going to get
okay. So the situation
they
in
think
Sweden,
it's going to happen. They really do.
It's
think
really
it's
hard to figure out, because they have done a lot of things that seem like they're taking this let her rip approach, but then Swedish officials come out and say, "Oh no, that's not what we're doing at all."
Yes, that's right.
It doesn't matter what they say; it matters what they do.
Yeah, I mean they're preventing people from wearing masks, and they're leaving things open. The fact, however, the undeniable fact is that they have by far the highest infection rates and the worst death rates, like by an order of magnitude of the whole Scandinavian bloc.
Right.
So if you're in Sweden, I think you're not allowed to go into Norway, because Norway is just like, no, we don't.
That almost could be the case no matter what, because they hate each other anyway.
Well, right. But, it's Scandinavian animosity, so it's kind of.
So this.
It relates to what happened in World War II, basically.
Yes.
This then leads to calls for letting the infection go. And one of them is the Great Barrington Declaration, which we talked about.
Which we trashed
last time. And I didn't realize the authors of that actually received an audience in the White House.
Of course they did.
And it sparked a counter memorandum from another group in The Lancet, which called the herd immunity approach a dangerous fallacy unsupported by scientific evidence.
Right.
Now, I've been asked over the last few weeks.
That should be called the Great Barrington Supremacy.
So, Alan, why does knowledge take so long getting from Western Massachusetts to Eastern Massachusetts?
Or most people in Boston would say it's the other way around. I'm on the disrespected side of the state.
All right. So then the article talks about what is herd immunity, and I want to redefine it, because I think it's misinterpreted, because unfortunately the word herd immunity implies immunity, but that's not what you get, actually. Herd immunity is when enough people are immune to an infection, then the chance of them infecting someone who's not immune, either by infection or vaccination, drops. And so those people are protected. But those people who are not infected or immunized, they're not immune. They're just not encountering the virus, right?
Yeah, that's right.
So that's herd immunity.
Measles provides a really good illustrative example of this with the vaccine, where if you get 99% of the population vaccinated, the remaining 1% is protected because the virus can't get a foothold.
Yes.
But if somebody does somehow import the virus and part of that 1% gets exposed, they'll get it.
Sure.
And if vaccination rates drop, they don't have to drop much, because measles is highly contagious. If they drop, into the low 90s or into the 80s, as happens in certain populations, then you immediately get outbreaks of measles, as we saw, last couple of years in Disneyland and that sort of thing.
Mm-hmm.
So then the article goes into a discussion of what is herd immunity? How do you figure out what you need? And it depends on the reproductive index or not. And there's a formula, but as they say, the reproductive number can be manipulated. And so it's very difficult to know exactly what the percentage of herd immunity is for SARS-CoV-2. We know it for other viruses because we have been studying them for decades. And one of these individuals say, herd immunity is something we can observe by certainty only in retrospect, maybe as long as 10 years afterwards. So it's not clear that we can say what the number is right now. And then it turns out that the population, this idea that the population in Brazil reached herd immunity just isn't true. And they're having more infections now and so forth. But then they talked to somebody from Sweden. The Minister for Health and Social Affairs told Nature, herd immunity is not part of our strategy. She said, we use similar tools as other countries, promoting distancing, protecting vulnerable people, carry out testing and contact tracing. And then the writer says, despite this, Sweden is hardly a model of success. So,
right. So, Vincent, does it mention at all what the original definition of herd immunity was with regards to animals? Because I think that's where it started. Was it because Rinderpest, or was it Louis Pasteur that established this for his rabies? Or
I think that it was first established in the veterinary community when thinking about the ability to protect one individual farmer's herd.
Right.
That is, again, an isolated population.
Sure.
Without a lot of people coming in or out, without a high birth rate. What
was the disease that they were using? Was it brucellosis or something?
I've only heard it as sort of a general veterinary epidemiology term. I don't know if there's a specific disease.
I know we have veterinarians listening. If somebody can write in and give us the original citation, that'd be cool.
Alan, I will never forget the first time I taught medical students here at Columbia. I said, I want to explain now herd immunity, and a bunch of students in the back went, moo. Can you imagine future doctors?
Speak up, we can't herd you.
I always thought that was funny. All right. And then finally, the article closes by re-emphasizing, we've never achieved herd immunity through natural transmission. It has to be done by a vaccine. And even the natural infection by these common cold coronaviruses doesn't appear to do that because people get reinfected all the time.
They still circulate. Yeah.
So this emphasizes that the vaccine needs to work.
Yeah. The vaccine, at least one of the vaccines needs to work. And the only way we're getting through this is with a vaccine. We're not getting anywhere close to normal with this herd immunity process. You're just going to kill millions of people unnecessarily.
So my impression is also that anti-vaxxers are using this as the excuse for them not to get immunized. We don't have to because there's so many people immune that we've got herd immunity working for us. Like for polio, for instance. Or
people who are in that camp are not going to be.
We're not talking to them.
Yeah, we're not talking. Anybody who's on the fence, we can help persuade.
But the fallacy with that,
I have Wikipedia here on the history of the term herd immunity.
Good.
The term herd immunity was coined in 1923. Herd immunity was first recognized as a naturally occurring phenomenon in the 1930s when A.W. Hedrick published research on the epidemiology of measles in Baltimore and took notice that after many children had become immune to measles, the number of new infections temporarily decreased, including among susceptible children. In spite of this knowledge, efforts to control and eliminate measles were unsuccessful until mass vaccination using a measles vaccine began in the 60s.
Yep.
Yeah, part of the problem is that new kids are born every year and they're put into the pool and they increase.
Sure.
By the way, the fallacy, Dixon, of this idea that the anti-vaxxers are protected doesn't work because we see outbreaks of measles in communities where entire communities decide not to immunize and all herd immunity goes out the window.
Yeah, exactly right. Exactly.
Or out the barn window, I guess.
There's some really interesting epidemiology dynamics in the smallpox era, comparing the occurrence of smallpox as a function really of population density. And I never really understood this until I heard a good historical talk not too long ago. Actually, it was a talk that a Zoom thing from a group that Kathy's part of that she invited me to attend. And basically, in some areas, smallpox was really endemic. In particular, urban areas like, Paris and London, where the population was high enough and dense enough so that it never went away. And you knew your children were going to get smallpox. God, this is really terrifying to think about. You knew your children were going to get smallpox, and that had a 30% mortality rate.
That's right.
And it was just a gruesome disease. And even if you survived, you'd be scarred. And there were other sequelae as well. I just can't imagine living with that. But there were other areas, and I never really understood this, where it wasn't really endemic, but it was epidemic. Okay. And that has to do with areas that, and this goes back, there's a particular epidemic in I think it was the early I forget exactly when it was, in Boston. It's a famous one that was an outbreak, and there the population was low enough and thin enough so that it really wasn't dense enough to support endemic replication of the virus. And so you could go through a generation or so without a disease really running through the population big time. But then you'd accumulate enough susceptible people so that the virus would be introduced and just slam them. Okay. And then you'd go through the same thing again.
Rich, have you ever read the book Pax Americana?
No, I have not.
Because it talks about smallpox in the history of the early United States. And a lot of those things are discussed. I read it in college and it is fascinating.
Good.
Things like Revolutionary War troop movements based on smallpox epidemics.
Right. Have you ever seen a movie called Black Robe?
No.
Yes.
It's a remarkable movie.
Yes.
It includes the demise of the Huron Indians as the result of being given blankets laced with smallpox.
Right.
Alan, you had some.
So yeah, I understand. A lot of people have been emailing about the herd immunity discussion, and there's an interesting point that we probably ought to discuss here, which is, okay, so this Great Barrington version of herd immunity is bogus and is not going to work and is just going to kill millions of people. What should we be doing is the question. And, you know, legitimately, we're poo-pooing one approach, which is an extreme. The opposite extreme would be going back to mid-March, locking everything down, closing all non-essential businesses nationwide. You know, nobody goes anywhere, nothing moves. We've talked a lot about what we should have done 8 months ago, and that's important to remember for the next pandemic, which could be around the corner or 100 years from now. But what would be the appropriate action? Let's say, you know, suddenly things get fixed in Washington and you're put in charge and you have absolute authority to figure out what the national response should be given the current situation, with case counts ramping back up in many, many states and things looking bad for the winter. What should we do?
Well, you know, as Rich said last time, it's now too late because virus is everywhere. So seeing what we should have done 8 months ago is not going to work anymore. So I think what we need to do is we can resume our lives as we are now, but we need the distance. We need to reduce class sizes. Restaurants here in New York, you can have 25% capacity. You have to wear face masks, and not everyone is doing that. It does make a big difference. And minimize your going out and about. Don't do non-essential things. I think you can control it without having a complete lockdown, because I do think we can't trash the economy completely. And so there's got to be a middle ground. And then, of course, the key, and I don't know why still we don't have rapid, cheap antigen tests. We're 10 months, 11 months in. This could have been done months ago, that everyone could be tested multiple times a week very cheaply. And that's what I think we ought to be doing.
Vincent, do you have any feeling of how, if we threw a lot of resources at it, which we're not doing now, how soon we could have an antiviral that you could just take if you got infected?
Well, you know, Lisa Grolinsky told us on Wednesday that there's a promising remdesivir-like drug that's orally available in phase 2. I mean, you can't rush these things, right? You need to bring them through the phases. So I think that a lot of things are going on we're not hearing about. We're just hearing about the vaccines. But
we are putting a lot of resources into that type of, you know, protective measures and response measures. But yeah, as Vincent said, you're not hearing a lot about them.
But that's just a hope for another magic bullet, which may or may not appear.
Right.
Yeah, that's right.
So I may have said previously that it's too late, at least in one respect, from the point of view that yes, the virus is everywhere, and in fact, I think that has a profound effect on the dynamics that we're seeing now, because the emergence of the virus in the population used to be a function both of spread over long distances and also local transmission and disease. Now that whole spread thing is gone. I think the virus is everywhere, so that in any given community, when you just relax the mitigation procedures at all, you get a certain level of disease come up. And it's my impression, and I have no real science about this, but I've been watching pretty closely. My impression is that the disease burden in any given community is really a function of the behavior of the people as a community. And that's all the things we talked about: masks, distancing, and hygiene. Okay. It's really pretty simple. And what I would like to see is that I think would really help is a national level, federal, coordinated response to this that is science driven. Okay. I mean, if you put me in charge, I'm even a scientist, but if you put me in charge, first thing I'd do is get together a big think tank of scientists that covered the whole spectrum of issues, epidemiology and, virology and the pathogenesis and et cetera. And also, a collection of experts in public health who knew what the issues were about, getting enough PPE, communicating with each other, data gathering, data distribution, and the whole thing. I think it needs to be coordinated at a central level, and a consistent and science-driven message needs to be put out. In the end, I think the solution, and every day is a new day. I may have said it's too late, but I also believe that every day is a new day. And we're probably not halfway through this. Okay. What are we, 10 months into this? Mm-hmm. There's at least another 10 months. There's probably another year. As a matter of fact, I think that in many ways, in terms of disease burden, we probably haven't even seen the peak yet.
Or we're in one of the long-term infections.
We're in one of the worst situations right now, because in any given, the hospitals are starting to fill up again and being overburdened. Okay, and in any particular area, if we drop our guard, it's going to be really bad in terms of the public health care. But I think we've also learned a tremendous amount, and I think Vincent is right. I think that there's a middle way. I think all of these very simple measures, if applied consistently and respectfully, okay, we can approach something that's normal with our faces covered. I had a guy over today to fix a bedroom window, and it was great. He showed up in a face mask. Okay. I was wearing a face mask. He fixed the window. He went, and I'm sure we're both going to be fine. It's so simple. And I get the impression, in fact, that schools actually, I want to see, and here's where a federal response would be good. I'd like to see good data collected on the schools. It involves a tremendous amount of testing. I left that out of my federal plan, but testing both in terms of for disease and for serology, okay, at least as data. I'd like to see a lot of testing in the schools to understand the dynamics of transmission under different mitigation procedures. Because I know here in Austin, there was just another paper today about another article in the paper today about how the amount of positive virus cases in the schools have been rising in Texas. But if you read the fine print, and in particular read the quotes from our local public health director, Mark Escott, it's not necessarily an increase in the schools, it's an increase in the school-age children. Okay? And the infection is not necessarily in the schools themselves, but it's happening because of the social activities that are peripheral to the classroom. Okay. And so the message is that the schools are actually doing quite a good job of mitigating spread in the school. But the community's not doing a great job of getting the message spread beyond that, so that when people are out and about, they pay attention. So I think all of the science needs to be put together at a central location, and the message needs to be consistent, and it needs to be focused on, as Vincent said, finding a middle way. We're going to have to learn to live a little differently.
Yeah. So sorry, Dixon.
No, go, please.
So I think that for me, the number one thing is Tetris. That we need to make sure that we are doing lots of rapid testing, but we also need to make sure that we have hired a full complement of contact tracers and are able to really do the testing and contact tracing the way it should be done. I think that then using all of our distancing and masking and ventilation types of improvements are really going to help, because it is going to get a little cold. It's going to be harder to spend as much time outside. And so thinking about ventilation is going to be really important. And I completely agree with what Rich was saying about needing sort of a coordinated response. And I also think about that as needing communication. Because I think that there are a lot of people who are not us, who are sort of uncertain about where the middle ground is. I can either stay home or I can sort of live my life normally. And thinking about sort of what small changes each individual person can make to help things out, and making sure we communicate that is going to be really important. There's actually a group of people who have put together a counter memorandum, is what they call it, to the Great Barrington Declaration, called the Jon Snow Memorandum, that different scientists and public health officials have signed on to, that proposes exactly what we're talking about.
Okay.
I actually received a few messages from people asking whether we knew about it and whether we had signed.
These things, though, these things don't help. It needs to be, as Rich said, implemented way above. Okay.
Yes.
Signing things is not going to get this done, especially now, because we have an administration that's not going to listen. I'm sorry,
Dixon
Dixon
has something to say.
Yes,
I do, because as the senior statesman of this group, I was
Not
born
by much, Dixon.
No, but still, you can't claim to be born at the advent of World War II,
That's
which
true.
I was. So if social marketing, I think what you meant to say is that if we could coordinate our social marketing starting at the top to convince everybody that we are at war. We're not at war with each other, although right now we are, but we're at war with an infectious agent that needs to be treated like the enemy. Just like during World War II, we treated all of our enemies, and we had to sell that to the country. It took an invasion of Hawaii to convince people that somebody out there actually wants to come and kill us. So how do you convince people who are not going to die from this that it's important to prevent my death, not yours? It's important for you to prevent my death. And what I'm going to tell you is that I'm the institutional memory. All right, I'm the gene bank of information, the information that you need to know in order to take your life to the next step. I'm your teacher, I'm your father, I'm your grandfather, I'm your great-grandfather. Those are important communication networks that need to be maintained. And if you look at who's dying from this, if I was 23 years old and I was an Olympic athlete, I guess I'd be worried about whether or not I had a little heart problem afterwards, but I certainly wouldn't be worried about dying very much from this. And there are people out there that are convinced that nobody is dying from this, and this is a fake news thing, and how insulting to those poor people who have lived through this and lost loved ones, lost compatriots. All of these things just come together into so much fake information, which is why I think social marketing has a huge role to play in this, and it's being subverted by somebody and some machine who thinks that we don't want to panic the people. That's not the real reason he's doing that. I'm just so frustrated by this.
So I think what I would suggest is maybe we should do what we did with healthcare reform, where we had a system developed in Massachusetts called Romneycare, and it worked so well, and it still works very, very well. I mean, it's got some issues, but it's a whole lot better than what came before, which was basically nothing. And then we rolled out Romneycare nationwide. And for some reason, around the time we were rolling out Romney Care nationwide, Mitt Romney decided he didn't want anything to do with it all of a sudden. But anyway, no, I know exactly why. But anyway, the result of that, which, got plagiarized and called Obamacare, ends up working. Okay. And again, it's got some issues and some stuff that could be fixed, but it's a whole lot better than what came before, which was no plan. And pointing to the COVID-19 response, I mean, sorry, going to launch into a little state pride here, but we started out behind the 8 ball. We were way up there in case counts back in March. We had a super spreader event. We had a whole lot of cases in Massachusetts, mostly in the Boston area, but they spread statewide. Springfield had a big outbreak. And we clamped down on it, and we got things under control even before testing was widely available, even before we knew much about the virus. And now we also set up the first contact tracing program in the country. So before everybody else was doing it. Now that other states have done the same thing, they're seeing the same types of results, and we're getting it under control, and we're able to use science-based measures to reopen things. And this is a critical point. There are numerical targets that, and I don't know if Massachusetts numbers are necessarily the best numbers, but they at least have numbers that say, if you have more than 8 cases per 100,000 people in your town, you're in the red zone, and you can't reopen this list of businesses. If you have fewer than 2 cases per 100,000, then you're in the green zone and you can reopen these businesses. Now, unfortunately, in Mass, we have this town-based system where it's like we've got 300 individual countries glammed together into a state. I really wish they would do it on a somewhat wider level, but they've done a pretty good job coordinating the state to the extent they can. If you scale that up nationwide and had a national system where we said, okay, every state, we're going to have contact tracing systems. Here's how they're going to work. CDC sets the standards for them. Here's what this means and what your parameters are for reopening your state. You want to reopen Florida? Okay, well, here are the businesses you can reopen based on your case counts. And test positivity rate is another thing that's being tracked. Now, having said all that, I will go ahead and point out that the latest news I've got in Massachusetts is that our case counts are coming back up. So even if you do it all right, you've got to watch out for that second wave. And we are now starting into it. We're up to almost 1,000 cases in the last daily report, which is way, way up. Our test positivity rate is above 1%, which is not where we wanted to be. And we need to keep an eye on that. And I think hopefully what's going to happen is that we'll clamp back down and try and say, okay, maybe we have to reclose the restaurants for indoor dining. Maybe we have to close the bars again across the state. But roll out a system like that nationwide. And that would be my policy approach, my alternative to this letter rip.
Alan, why can't we? What's the obstacle to doing that on a national level?
Trump. In a word. I mean, the administration. So this is absolutely something that could have been done on a national level, coordinated by the CDC, that could still be done on a national level, coordinated by the CDC. And there is the issue of federalism. States will say, oh, we have states' rights to do this. But if you are declaring a national emergency, then it provides wide authority for the federal government to say, okay, yeah, you have states' rights, but this is an emergency, and here's how you're going to respond to it. And we don't care if you're the governor of Florida and you think you're your own thing. You're going to have testing, tracing, and isolation, and you're going to close your bars because your case counts are too high.
There's one thing I'd like to throw into this. I think there's economic relief has to be part of this whole package.
Absolutely.
And I think it's really important to understand and appreciate, and this is partly a shout out, okay, that there's differential sensitivity in the economy to the effects of the pandemic, okay? Yes. Most notably bars, okay? Yes. I'm sorry, okay? But due to nobody's fault or anything else. A bar happens to be one of the worst possible places for spread of the virus, okay? And that doesn't mean that bars are evil or the people who run them are evil or anything like that. It's just an unfortunate circumstance. And I think that needs to be taken into account, that those particular industries are getting hammered more than others. And it's not just bars. I mean, theaters, I think of in particular, and restaurants to a somewhat lesser degree, because there are measures that they can take to mitigate the damage. But I think all that has to be taken into account in trying to find this middle way. Okay, certain behaviors, including economic relief for the people for whom there really aren't any appropriate mitigation procedures available.
Yeah, and there are the government of the richest country in the world has an immense amount of power to relieve a lot of the problems people are complaining about with the lockdowns. Mm-hmm. They're saying, okay, well, this leads to depression, and this leads to, all these problems. And a lot of those problems are not problems of unemployment or problems of sitting in the house. They're problems of poverty. Mm-hmm. So being unemployed is not in and of itself a big deal for most people. In fact, for most people, their goal in life is to be unemployed. It's called retirement.
Hey, Rich, right? You and I.
And people save their whole lives to have enough money to be unemployed. And they say, yay, I'm unemployed.
That's right.
And the key is they're unemployed with money. And if you're unemployed, but you still have a roof over your head and you can still put meals on the table, it's a lot less traumatizing than if you aren't getting that next check. And I have friends who lost their jobs immediately when the lockdowns hit, and who have said, it was a huge deal to get those checks that were sent in the first relief round. And luckily, the couple of friends I've corresponded with on this have actually managed to find new employment since then. But for those who haven't, that has run out. And that's something that absolutely needs to be fixed. And that by itself addresses a lot of the underlying logic behind these herd immunity proposals, which is, we got to get our economy restarted. Okay, yes, we got to get our economy going again. But in the meantime, we can take care of people. We do have the resources to do that.
The problem is also, if you don't mind me adding on to this, is that we have no universally accepted voice of reason in the government or in politics or in entertainment or in sports or in science. And you can see how easy it is to undermine science. All you have to do is just say, well, he doesn't know everything. Well, who the hell does?
Hey,
that's why there are 5 of us, not 1.
Hey, is TWiV chopped liver, Dixon?
Yeah, well, no, chopped liver isn't so bad, actually, if you look at it in a certain way. The point is that you need social marketing at all kinds of levels. You've got to be able to talk to the people that go to Sturgis. That's not a religious form, although there is something
I would classify that as a religious
Burning Man. You've got all these huge gatherings of younger people that need to be talked to in a way that makes sense to them, not to us. And we aren't doing that either. And in fact, this person is pandering to those people, and using them as his foil to say, see, it doesn't affect them. It doesn't, it's really crazy. That's what's going on, to be honest. It's counterproductive. No, the biggest argument for opening up the country again is to do everything right, not to do everything wrong.
Yes.
And why doesn't anyone just say, well, excuse me, that's not true. Here's what happens when you do it right. And, China might be the best example of that because their economy is now back on growth. And they're very draconian.
We can't necessarily emulate China, or we certainly can't. We cannot emulate a small, isolated, cohesive country like New Zealand or South Korea, which was able to lock it down. They did a great job early on, but we're not early on, and we're not those places. We're more like Spain or Italy or France, where they're struggling with this very same issue.
Yeah, that's
they're seeing their second waves coming up, and I think the key is one major key is to have quantitative thresholds where you say goes above this number, Here's what we do. And then you don't have to have these arguments about, well, we could do this, we could do that.
Right.
Nope. It went above the number. We're done.
That's right.
This conversation's over. You're closing it.
Exactly.
And then it comes back below that number and you don't have to have that discussion again. You say, okay, came below that number. We're reopening it.
You're going to get
You're going to get an up and down, and that's
right. But the peaks
going to
will be
happen. I just got an email from our local school that they've had some positive tests, and they may have to go to pure online learning because the number.
But that's why you can't let it go on a state-by-state basis, because some states will say, we're not wearing face masks, we're open up. And others. So it needed to start from above, and I don't understand why it couldn't.
And it could still be done from above, and hopefully we'll get it done from above sometime soon.
That's right.
I mean, this will be written about for years and saying
decades,
what happened.
Centuries, yes.
And, I don't know what happened, but I suspect very early on the president didn't want to acknowledge it. And then he got too far into it and couldn't turn back. And I don't know. It's just unfortunate.
Yeah.
I just don't know. All right. One more brief thing. I've always
thought. Yes, we're an hour into the show. We have one more brief item. Sorry, that got a little extensive.
Dogs. This is for the dogs, really.
Yeah.
So they can go walking, remember? I have always felt that in this pandemic, pharmaceutical companies should not be secretive. And I have encountered secrecy over and over again. It burns me up. And this article in the Times kind of addresses that by Grady and Thomas. It was published at the end of September, but Moderna and Pfizer reveal secret blueprints for coronavirus vaccine trials. And Daniel Griffin talked a little bit about this earlier, about the numbers they're needing and the timeline and so forth. And the article basically says, this is unusual. They're abandoning their traditional secrecy and releasing comprehensive roadmaps of how they are evaluating their vaccines. Of course, people have been demanding this. We want some transparency to know if these are going to be tested properly and so forth. So I'm really glad to see this. And I think this is the way it should be in an emergency like this. There is no need for you to be secretive about your product. You know what? If someone else finds out and does it better than you, that's good for everyone. It's not just about your company and your profits and your bottom line. And I'm glad they're doing at least this, but of course it's going to take a lot more.
It's really hard for companies to get their corporate minds around this.
I'm sure.
You're talking about companies that compete directly against each other. Why do you think we have like 5 different medications that are all basically the same thing to treat the same disease? It's because they all want to sell that drug. So this is antithetical to the way they normally do business. They are not at all accustomed to disclosing this. They don't have procedures for disclosing this type of stuff early on. And they've got, layers and layers. A company Pfizer or Moderna, Moderna a little less so. They started out as a smaller company, but Pfizer is immense. Yeah. And just the layers of lawyers you'd have to go through to have this discussion. And what can we disclose? Sure. You never asked what you could disclose before. This hasn't come up.
I understand.
So yeah, I totally agree that they need to be open about this, but I also understand that they're doing a hard thing, and I want to applaud them.
I agree. It's a good point, but I do also think if we had a top-down arrangement like Rich was saying, then you'd say, okay, what do you have? Get them all in the same room. What are you doing? Yeah. Here's what we need you to do.
And that, to the credit of the 3rd and 4th tier people in places like CDC and FDA, that has actually happened. FDA in particular, where we had someone on the show just recently who was giving us the rundown on this. FDA has been very good about getting the companies in a room and having those discussions, and also NIH and CDC. And again, these are lower level folks who've been at these agencies for decades, and they know how things are supposed to run, and they can talk to these companies and have them all get on board. It's taken some effort.
I understand. I understand. there's a corporate mentality, and I can hear people in companies saying, Vinny, you don't know how it works. I don't care how it works. Fix it. This is an emergency. The biggest
Vincent,
emergency.
You've lived with somebody most of your adult life that knows exactly,
how this works.
Oh, yes. You do know how that works. Now, your nose just got a little bit longer when you said you didn't know how it worked.
I still don't know how it works. I can have.
Well, maybe your wife doesn't either then.
No, she knows.
No, I'm sure
but
she's familiar with it.
Knows way more than I do, and I am still ignorant in the ways of companies, and I'm sure I am. The point is, this is one of the biggest emergencies we've had in many, many years, and you should figure out how to get over your secrecy crap to fix it, okay? And I ask people in companies, so what are you guys doing? Oh, I can't say. It's a big secret. Oh, screw that.
Proprietary.
Screw that.
It's not secret. It's proprietary.
It's proprietary, yes.
So one of the most insidious things about this whole thing is that the virus kills only, in quotes, 0.5 to 1% of the people it infects. And so it's the same sort of problem with vaccines. Most people just don't see the problem. They don't experience it. So so those who don't experience it, in order to get them on board, they have to somehow be convinced that we are a community, and sometimes we have to, act as a community to help each other out, and that's where also from the top down, rather than divisive behavior or a divisive measure, there needs to be I'd say divisive message. There needs to be a message of unity and community. And, this is a legitimate scientific consensus of what needs to be done to bring this under control, to help everybody out. Come on, get on board.
There was a huge opportunity for this recently when the president contracted SARS-CoV-2. There was an opportunity for empathy, for unity, for saying, this can happen to you, it's bad, don't get it. Mm-hmm. And the opposite was in fact done.
Exactly. Exactly.
So that's,
one of his
I would agree that that's the kind of attitude that you need, that we need to understand that we're all on this.
Yeah.
Every day is a new opportunity. Even Chris Christie.
I was just going to say.
Yes.
I was just going to say.
It's amazing. He said, okay. He actually said, I was wrong. Okay. Yeah, well, I did the wrong thing. And everybody needs to get on board and wear a mask.
Yeah.
Yeah. Rich, he was in ICU for a week though.
Yeah.
Trump was not. Yeah. And it's quite amazing to see what he was willing to experiment on himself in order to try to cut short the time that this virus lived in his body. And it's just really disgusting to see how he badmouths science left and right. And then all of a sudden, now that he's got it, he needs to absolutely throw himself at their feet and say, please, please, please help me. And that's the most insidious part of what happened, I think.
And kudos to Chris Christie.
Yes.
Yeah, eventually, he did see the light. He did see the light.
I know 1 to 2% of people die, but I know a couple of people who have recovered months ago, and they're still not recovered.
Oh, yeah. The deaths are only the tip of the iceberg.
They're
that's
tired.
Exactly right.
They have headaches. They can't catch their breath. It's really messing with them. And
how is Ian Lipkin doing? Last I heard,
I was just going to ask,
having some breathing problems.
He told me a few weeks ago, if he walks up a little bit of an incline, he has to stop. He can't catch his breath. So something's been, I don't know, maybe some heart tissue was destroyed. You can't pump.
Or lung tissue.
Well, you got a lot.
And the other thing, the other thing is that let's not forget that 1% of the U.S. population is 3.3 million people. It's a lot of people.
Right. And it's not as though any of those people are expendable.
No.
It's not as if, people who are in some of those high risk groups are not people that are important for us to protect.
Yeah.
And I can make a whole list of people in my life who I care about.
I think about cases like just up the road from me. I mentioned this before. The Holyoke Soldiers Home was one of the early horror shows in this whole thing. It's a veterans home So it's a retirement facility. They had a couple hundred people there, I think, and they just had the virus just burned through there like a fire and just killed, bunches and bunches of people who, these are people's grandpas and they served their country and we're taking care of them and we can't even do that right. And now they're dead. And
you're so right.
That's awful. That's
very
just
disrespectful, among other things. So there's another disease out there that everybody knows about, and it's got a similar mortality rate, and that's malaria. Malaria occurs in the tropics among mostly poor people who live in semi-rural settings. And who cares about them anyway? And mostly the people who die from this are not adults, they're children. They're newborns. They're like 2 months, 5 months, 6 months old kids. So it's hard to rally the entire world around something that doesn't happen in their own backyard, whereas this disease should have galvanized. Vincent, you should have a vaccine institute someplace where all the brains of the world come together and work for 3 months and solve it and then go back to their jobs. Why not?
Could have been
like
done.
a volunteer fire department. Yeah,
exactly right. Why not?
Could have been done. Could have been done. Yep.
That's what I'm sure you would do that if you were president, Vincent, and I would work for you, not with you. I would work for you.
Well, if someone,
that's how far I would willingly go.
If a leader came to me and said, organize an institute to deal with this, I would do it. I would know who to contact and put together for sure.
Just do it.
But
and pay high salaries.
I'd call Harold Varmus and say, Harold, I want you to organize an institute.
Yeah, that's right.
I would call other people. Yeah.
Yeah.
I got a podcast to record.
Yeah.
I want to do just a little bit of science here.
Yes.
Before we move on to email. And there are 2 papers came out this week in Science indicating that neuropilin 1 is somehow involved in the entry of SARS-CoV-2 into cells, okay? We actually talked about neuropilin 1 on Wednesday because on certain cell types, it actually is a pain transducer. And so it turns out that the spike glycoprotein of SARS-CoV-2 will bind neuropilin 1. And in last Wednesday, we showed that binding actually inhibits pain transmission. So it's an analgesic. Whether or not that happens in people, we don't know. But if you're interested in why people looked at that, these 2 papers address it, okay? And now they both have similar experiments. So let me try and summarize. I will say at the outset, I am not buying it yet because the experiments were done in irrelevant cells in culture and the effects are not huge. I'd like to know if neuropilin works in an infected animal, and we don't know that yet. But let's just say that neuropilin 1, why would you look at neuropilin 1? Well, it turns out that when the spike glycoprotein of SARS-CoV-2 is cleaved by furins, remember, it has an unusual furin cleavage site in the spike, and that's essential for infectivity. It exposes a peptide sequence, which happens to be this consensus sequence for binding neuropilin 1. It's called the C-end rule. C, as Alan says, sender.
Sender. C, capital C and capital R. It's the sender rule.
So, in fact, someone looked at it and said, oh, look, these amino acids are part of the C-end rule. So let's see. And they found that, in fact, spike will bind neuropilin. The isolated proteins will interact with each other in cells. And if you mess with the C-end sequence, you can block that interaction. If you have, now in cells in culture, and they use human embryonic kidney and colon carcinoma cell lines and HeLa cells, none of which I care about in the context of SARS-CoV-2. If you put neuropilin in, it enhances infection. And if you have without neuropilin, just ACE2 receptor, the virus infects, of course, but it's better if you have neuropilin present. But I must say the effects are minimal. They're one of these papers, they say, alone, NRP1 hardly promotes infection of human embryonic kidney cells, but co-expression with ACE2 markedly enhanced infection. And I would say you shouldn't say markedly because it's a few-fold effect. And, markedly is like a qualitative imposition on the
They
data.
used a highlighter, and so they marked it, and so it's markedly changed.
That's right.
And
So if you make monoclonals to neuropilin, they will reduce infectivity as well. It doesn't seem to be involved in virus binding to ACE2, but at some subsequent entry step. And then this may be the most interesting data. If you look in patients who have SARS-CoV-2 infection, the cells that are infected have neuropilin-1. They produce it, and I look by RNA sequencing, which doesn't mean that the protein is actually there, but the RNA transcript is there. And then they look throughout all the human tissues for RNA of neuropilin-1, and they say they're abundantly expressed in all pulmonary and olfactory cells. In particular, the olfactory epithelium seems to have a lot of neuropilin, which is interesting because there the virus can reproduce and cause loss of smell, right? So, the results are all consistent. And I think
they also, one of them, they cite this finding that NRP1 and 2 are upregulated in lung tissue, especially in COVID-19 patients.
A lot of data which makes sense.
A lot of circumstantial evidence going on
here. But as I said,
yes.
the effects in culture are minimal. They're not in there. I'd like to see it done in human lung cell cultures, perhaps in a mouse model. And one thing I thought, well, maybe we could look for SNPs in the genes for NRP1 and see if there's any correlation between serious or not serious disease and SNPs in this gene.
I was thinking the same thing.
So that would be good. By the way, these are two very large groups in all over the world, labs all over Europe and Asia and so forth. And they're two different laboratories, and they do slightly different experiments, but many of the same ones as well. Is that a reasonable summary of this?
Yeah, I have something to add because I started getting teleological about this. I started, flipping out in my head and trying to figure out why. What this is all about. There's one experiment in this that is relevant to my query, and that shows that blocking neuropilin-1, I forget quite what the setup was, but the blocking this interaction does not prevent binding to the cells.
Mm-hmm. That's right.
But it does prevent uptake. Okay,
right.
So the step that we're talking about is the uptake of the virus.
Right.
And so I'm wondering, okay, so how does this work? Because after that cleavage at the furin site to expose this interaction, the interaction isn't going to take place until you've cleaved S1 from S2.
Right.
Okay. After that happens, S1 actually can and ultimately does, I believe, leave.
Yeah. That's
that.
right. It falls off.
The S2 rearranges and you get the fusion.
Correct.
So S1 in my mind is kind of off doing its own thing. So what's this about?
That's a good question.
At the same time, my understanding is that tweaking neuropilin-1 induces endocytosis. Okay. Mm-hmm. So I'm thinking that if you have some sort of a local interaction here, that you cleave and S1 goes over here and sort of pushes a button that induces endocytosis and helps the whole thing be endocytosed, but that doesn't have to happen. Okay, so it could help, but is not absolutely essential. That's the way I'm thinking about it.
Could be, yeah.
The one sort of thing that I would worry about is whether this would work for a mouse model in terms of having some of this work in the mouse system. But one of the two papers does a little bit with using, with putting this peptide onto some particles and looking at internalization of those particles.
Right.
And so it does look like this will bind to mouse neuropilin-1 and lead to internalization. So it means that those mouse model experiments that Vincent was talking about are easily something that can be happening.
Yeah.
So am I correct that entry of SARS-CoV-2 can occur either via endocytosis or by fusion of the virus particle directly with a plasma membrane?
No, I believe you need low pH for fusion. So you need to go in to the endosome.
Okay.
Anyway, so it's kind of curious. Now, the press is saying this explains why SARS-CoV-2 is much more infectious than SARS, because SARS spike doesn't have a furin cleavage site, and that's not correct. It's not correct.
I think this may be some speculation that some of the authors might have made.
I'm sure
that ended up in the press release, and so it got covered. I was actually a little annoyed to see when I saw these in. I hadn't seen these papers at all or heard about them, and I saw them in the TWiV notes, and I pulled them up. And I said, "Oh, cool! We're gonna dig into some basic viral entry stuff with SARS-CoV-2. That's fine." And then I was looking at Google News, and I saw that these got coverage in big news outlets. Why?
Yeah.
And then I said, "Oh, that's a real reach."
Yeah. Now, I mean, that's one reach, and the other is they're saying, "Oh, this could be a therapeutic target," but
maybe
I don't know, because the effects are not 100% or even close.
Yeah.
So I'm not sure that's the thing. I think from a basic science viewpoint, this is interesting. If it turns out to be involved, what is it doing? As Rich was speculating, that's very interesting to us. But I think in the view of the pandemic, is not going to really contribute. Right?
Yeah, this is a very cool basic virology finding that I would have liked to see done in a paper with a little more meat in it. Like a more extensive analysis where maybe they actually go to the mice and proceed to the next steps. I am assuming that the reason that didn't happen was that these two groups realized that each realized the other one was breathing down their necks, and they needed to get a paper out fast, and so they just put it out there, and so it is an interesting finding. But
this won't be the last we see of this.
No,
we will. It's not the last we're hearing about neuropilin and SARS-CoV-2.
The two groups should have distanced better from one another.
Yes.
So did the authors or one of the authors of the both groups call the press, or does science actually call
all
the
of the
press
above?
To say we've got these, all of the above.
No. Given the number of institutions and the level of institutions involved here, I'm sure there are multiple. I haven't even followed how many press releases there are about this, and science puts one out as well.
Were these actually? I don't know if back to back is a thing anymore. Are they? Are these actually back to back papers? Are they in the same issue?
I don't know.
I think they probably will be. I think they're both online only right now. There's no link to sort of the pages or the volume at this point, but I think they will be back to back.
Mm-hmm.
And I think these would be papers that we might have talked about pre-pandemic in terms of just cool virology.
Yes. Yeah.
But I don't know that the press makes a whole lot of sense.
I can recall pointing out to Vincent, and the same response then as we're getting now, that I just read something about neuropilin 1 might be, and then I got cut short somewhere along the line there, because obviously I don't know as much about that as a lot of other people. So it's interesting to see this thing surfacing again. And I'm sure a lot of other groups are going to pick this up too and look at that as well. But
sure.
Well, as I said, Dixon, this is involved in pain pathways. Nerve cells and the spike.
But not smell or taste.
I don't think anyone's looked.
Right. So.
But it is involved in pain, as we talked about last week, and the spike binding to this is an analgesic, so it's interesting. I just want to note that back in 89, Kathy Mendelson in my lab identified the cell receptor for polio, one of the first cell receptors identified for a virus. We got no press. Of course, Columbia didn't send out a press release because they probably didn't even have one. They didn't know what it was all about. And the
whole science press process was very different back then.
Yeah, I'm sure.
Oh, I knew somebody at NYU that used to call and say, I have a breakthrough. And then he would list his breakthroughs that he had.
Yes. So,
and the Times would, they got inundated with this, obviously, and they wouldn't listen to him anymore.
So David Baltimore used to have people call him every week and say, what's new? And so I had been in postdoc with Dave. We had made this infectious DNA copy of poliovirus, which was a new thing. And Harold Schmeck from the New York Times, a science writer, called David. He said, David, what's new? And he said, I got this thing here. And so Schmeck wrote it up for the New York Times. Otherwise, it would never have been. And one last tidbit. It ended up on page 2 or 3, and Schmeck said it would have been page 1, but that was the day of the first shuttle launch, so we got bumped. Can you imagine? And here's the title of the article. I remember it to this day. Poliovirus made from artificial genetic material. I was like, come on. DNA is DNA. It's not artificial. And the first paragraph,
didn't make the first
scientists at MIT have reconstructed poliovirus from off-the-shelf chemicals.
That's a good one.
Well, you used some off-the-shelf chemicals, I'm sure.
I came to live with that, yes. I kind of got it, yeah. Anyway, Harold Schmeck. Let's do some email. Yeah, we're going to do like one round, then we do picks. Brianne, can you do the first one there?
Sure. Simon writes, love you guys. Here in Santa Clara County, California, Bay Area, where days are still warm to hot, nights getting cooler. To be allowed into China, you may need an invite. My wife was Chinese, now American, as China doesn't allow dual citizenship. She's arranging a trip. She needed an invite letter. When she arrives in China, she has to quarantine for 2 weeks in the hotel. By the way, Santa Clara County and California are obsessed with testing positivity rates. This is driving, I believe, bad behavior, which is to open up. They encourage lots of testing, as more testing will improve the positivity rate. Santa Clara County just moved from red to orange through this, so can open up more. However, the last 2 weeks, infected numbers have drifted up, and our R reference is hovering between 0.95 and 1 as an average, various estimates between 0.9 and 1.1. The California measure just uses infected per 100,000 and testing positivity rates as the only numbers that we care about.
So I confirmed this with a colleague of mine here from China, and he said yes. And he said you have to go to a hotel, and you have to pay for it, and they have to deliver all the meals outside your door, and you have to pay for them too, because you can't go out. Can you imagine what that would cost?
Wow.
And he said, but if you go to Shanghai, it's only 10 days, but elsewhere in China, it's 14 days. I don't know, maybe the food is more expensive there.
Message about Santa Clara County is important. I think that you need a sort of a multifactorial approach to deciding to the extent to which you can open up.
For sure.
Yeah, test positivity rate is important, but you need to not allow people to game the system. Cases per 100,000 is a pretty good measure to include in there. Total case count is a good measure to include. So there are ways to prevent this, but you need multiple measures.
And this goes back to what Alan was saying about needing to have sort of a number that is the definition that we all agree on.
Sure. Yeah, and we do this in aviation where there are minimums and parameters for things, and it saves people from saying, these clouds aren't that bad. I think I can get, it's at this altitude, therefore you can't do that.
Right. So in all my visits to China, and I've gone I think 5 times, at the Chinese mission in New York City where you get your visa, you have to show them a letter of invite before they'll give you that visa. And then if you're a business person, they sometimes give you 10 years worth of entry without having to go through that again. But I needed a letter from the people that invited me each time in order for them to
even pre-pandemic that was necessary.
Yeah, absolutely. Absolutely. They didn't want you to move there or spy on them or whatever else.
I was going there to adopt a kid, so it was a different procedure. We didn't I don't think we had an invite per se. Well, actually, I guess we did from the orphanage.
Sure you did. Sure you did.
Alan, can you take the next one, please?
There was so much other paperwork in that. Okay, so that was Simon. So this is Ron?
Yes.
Ron writes, hello, Dr. Racaniello and team. I'm a listener for the past 3 years and have enjoyed your podcast immensely pre-pandemic era to the present. Thank you. Like Dr. Griffin, I'm a physician specializing in infectious diseases in San Francisco Bay Area and have been immersed in this pandemic for months. Many times I've thought to contribute, but haven't. I'll get to why now is the time in a minute. First, I want to put a little wrinkle in the school reopening controversy. Certainly, rapid testing would be ideal and truly minimize transmission in the school environment, but I question whether it's a necessary requirement in order to send kids to school. I draw on our experience in the hospital setting. I spend much time in much of my time in a healthcare system with 500 to 600 acute care beds and thousands of employees. We have had in total 5 employee infections due to occupational exposure. There have been 77 community-acquired cases in our employees over the same period of time. None of the 5 occupational exposure cases were contracted from other employees. This supports the effectiveness of measures that can be done at schools: masking, hygiene, efforts to distance, although not fully achievable in a hospital, and not working when sick. My second reason for writing is an anecdote regarding the CDC that I would like to share. At the height of the Ebola scare in October 2015, I was called to go into the hospital for a febrile patient who had just returned from Nigeria. The entire ER was in an uproar and no one would go into the exam room. 2 vice presidents for the health system were camped out by the room at 3 a.m. when I arrived, wringing their hands. I spoke to the CDC hotline regarding whether there were any cases of Ebola in Nigeria, and they assured me that there were not. As you may recall, the 3 countries of concern were neighboring Liberia, Sierra Leone, and Guinea. I waltzed into the exam room, obtained a history and blood, and diagnosed falciparum malaria, which I have to say, when I saw a febrile patient who just arrived from Nigeria, was immediately what popped into my head. It's also what would have popped into my head for Liberia, Sierra Leone, and Guinea, because Ebola, even though it was going on then, was not the most common thing that you could get there. Anyway, continuing. If this same event occurred now, I don't think that I would be quite so accepting of their word that just because this man was from Nigeria, he did not have Ebola. But the reason why I'm writing is that I very much enjoyed hearing Amy Rosenfeld. She added so much to the discussion, and I loved her wit. I suggest that next time she is a guest, her mother should join in. You are Orion, and we are but the arrows of knowledge that you send worldwide to disseminate science and attack illogical thought processes. Your listeners are a quiver of twivers.
Nice.
Thank you, Ron.
Very nice.
Nice.
Very nice. You know, this is a good point about schools, but, you know, we're only finding this out now, right? So it will inform what we do in the future. And it may be that next semester we can do more. But I don't think you should say because it's not been an issue, we shouldn't have done it.
Right.
This way. Now, here in New York City, the infections in schools are very low. Same idea. But they're doing things, and that's why they are low. So I would say that doesn't mean we shouldn't have done this. It's just probably it's helping.
It made sense to take it slow.
Yeah. I still think we should have had the rapid testing going, but it would have helped as well. Dixon, can you take the next one? Dixon's frozen.
Without your mute.
Oh, yes, I did.
Carla.
I'm on point here. Carla writes, Dear Vincent et al., one of the greatest sources of frustration to me during this pandemic has been the difficulty of obtaining information. Obviously, part of the problem is that this is a new virus and much remains unknown. However, much of the media sells by generating an outsized emotional response, like fear, for example, and government officials need to use information to gain acceptance for their policy choices, making it very difficult to sort out the information that comes through news channels. In the midst of the madness, finding TWiV has been a gift. You are presenting important information to so many of us who are only asking to struggle alongside the scientists in an attempt to understand this virus and its implications. Thank you. One of the things I've learned from you is the difference between immunity to disease and immunity to infection. My question is, if a vaccine like polio protects people from complications of polio, but does not block transmission, can it still contribute to herd immunity if administered to enough of the population? Your conversations suggest that it can, but I'm wondering what the mechanism is. Thank you you want me to pause here?
You can finish.
Okay. Thank you for dedicating so much time to educating the public. I sincerely hope that you are able to build further on the platform you have created. Your efforts are sorely needed and much appreciated. The best, Carla.
You want to take that or shall I?
You may take it.
Whoever knows should take it.
Alan did his thesis on polio. He should know this.
Yeah, and you've worked on polio for much of your career, so you know it better than I do. But so quiz time for me. There are 2 polio vaccines. There's the oral polio vaccine, and there's the injected polio vaccine or inactivated polio vaccine that goes in your arm. We used to use in the United States, and what I got and what I assume everybody here got was the oral vaccine. That was the standard until very recently. Maybe Brianne's young enough to have gotten it.
I'm not sure.
Actually, I'm old enough to have gotten both.
Yeah,
To
me
have gotten-
too.
Okay,
Me too.
right. You guys.
Dixon probably as well.
I got
I like
both.
that
yeah.
little lump of sugar that they gave you, though.
Yeah, but you got injected first.
Right.
Probably.
Right. So the inactivated vaccine that's delivered as an injection, which is now what kids in the U.S. get, that provides protection against disease. It does not provide protection against infection because what you have is antibodies in your bloodstream. And this is an oral virus. So it goes into your mouth and it replicates in your gut. And until it gets to your bloodstream, it's doing fine. And it spreads out in the feces. And that's how the virus spreads. So that vaccine cannot produce herd immunity. Just the people are still going to be able to act as carriers.
But if you're
But
vaccinated,
it protects against disease. Why?
It protects against disease because you have antibodies in your bloodstream, so you won't develop the viremia, which is virus in the blood. After when you get the gut infection, you'll get just the gut infection. And then when if the virus is going to make the jump into your bloodstream, it immediately meets up with the immune system in the bloodstream, which is standing there with the brass knuckles saying, "Glad you made the trip. We recognize you."
so it will give herd immunity to paralysis, but not to infection, right?
Yes, right.
Which is what the letter is about, herd immunity to disease. Okay, and just to complete the trip here, if the virus has to basically get through the blood to get to the neurons and cause the paralytic disease.
Right. So it will provide individual immunity against disease, and everybody who gets the vaccine will be protected from disease. Or like 99%. It's a very effective vaccine. The one downside to that is because people who've gotten the inactivated vaccine can still act as carriers, they can spread it to people who are completely unvaccinated who could then develop paralysis. So it doesn't matter how many people you've vaccinated with the inactivated injected vaccine. If you've got one person in the population who has been completely unvaccinated, they could still get paralyzed. Okay, so you don't get to herd immunity of the sort that we would need. The oral vaccine is a live attenuated virus, 3, because it covers all 3 serotypes. It goes in, it replicates in your gut, but it can't get into your bloodstream. So it's a weakened version of the virus. And that provides immunity in both your gut and your bloodstream. That protects against infection. So people who got the oral vaccine won't act as carriers, although if they're immunosuppressed, they can sometimes just keep replicating the oral vaccine virus and passing it in the feces, and it mutates back to a virulent form. But that's a separate issue unique to the polio vaccine. So the oral vaccine can produce herd immunity. And in fact, it can also produce secondary vaccination. Mm-hmm. Because people are pooping out live attenuated virus, and through the same fecal oral route, it can spread to somebody else who then gets the vaccine virus, replicates in their gut, and they're now vaccinated, even though they never got the vaccine.
Right.
So it's a very effective vaccine for producing herd immunity. It does have some downsides in that it can actually cause paralysis, the very thing that it's supposed to be preventing, in a very, very small number of cases, which is why the developed countries switched over to the injected vaccine, which doesn't have that issue.
So I have a question. This is something I've been kind of thinking about in terms of how a SARS-CoV-2 vaccine might work. If this vaccine is able to give immunity to disease, but still allow infection, that means it's allowing the virus to come in and replicate in an individual. But we don't know, and I don't think we would know until the vaccine trials are done. Wouldn't it be possible for this vaccine to reduce the amount of virus in that infection or to reduce transmission? And so there could also be an effect on transmission, I was wondering as well, that could happen.
Yes.
Well, in England, they're going to find that out.
Well, maybe it's still in ethics review.
This is not
quite an
SARS.
interesting development, though, don't you think?
But she's asking about polio, not SARS-CoV-2.
Well,
Well,
but the nature of the
big picture, but
big picture.
Yeah, it's
the
just
nature
a
of the question, the
generalized
reason
question.
we're even
That's right.
discussing herd
That's
immunity
right.
is
That's
in
right.
terms of SARS-CoV-2.
So how many people before the vaccine came out, Vincent, in polio language, how many people had encountered the virus and never got sick?
Like 99%
Yeah,
of the people who got it.
So, I mean, is that hundreds of millions of people?
Yeah.
Sure.
Yeah. And what would happen is, for the best evidence that I've seen on it was the virus spread very effectively through a large population, and 1% to 2% or so would develop the paralytic case.
1% to 2%.
And everybody else would either get, a little diarrhea or nothing at all. So kind of a SARS-CoV-2 sort of situation,
Yeah,
except that the people who developed the complication were kids.
Yes.
And they developed a complication that was highly visible and terrifying.
Yeah.
Or the president of our United States.
you would have, some 8 or 9 year old kid who's out playing and running, and, a couple of weeks later, they're in a wheelchair. And they're in a wheelchair for the rest of their life. And
Right.
Timmy down the street, look at him. He's in a wheelchair. We need to be afraid of polio. So people took it very, very seriously because of that.
There is,
Sure.
and at the peak in the U.S., the post-World War II baby boomers, 40, 50,000 paralytic cases a year. And this has been happening for thousands of years. And we never got herd immunity to that. And many, many people were infected. By the way, this idea that the oral vaccine can immunize, as Alan said, Albert Sabin actually did studies. He developed that vaccine. He did some studies in Canada in communities showing that people who did not receive OPV were nevertheless immunized with it from community spread. So it's a unique feature of OPV.
Yeah.
That allowed that.
This is a really good conversation, because one of the bottom lines here is that it's complicated.
Yes.
And we really don't know yet enough about even natural immunity with SARS-CoV-2, and we know less about how immunity, hopefully it will happen, is going to play out with the vaccine.
And it's very dependent on the biology of the virus and also the response of the immune system. I mean, that's why we have vaccines that give herd immunity and vaccines that don't give herd immunity, and vaccines that you get once in your life and vaccines that you've got to get more often. And, it's just case by case. You get what you get.
And
Vincent, I remember one of our conversations a long time ago. You were explaining all of this to me in private and mentioned that the vaccine itself, the oral vaccine, could revert back to the wild type virus and cause polio. Mm-hmm. The use of attenuated viral strains of the SARS-CoV-2, does that have that as the potential caveat?
Wow, that's a good question. Now, the polio vaccines don't have many changes compared to the virulent viruses that Albert Sabin used to make them, just a handful. Right. But from my understanding, the attenuated vaccine being developed in China against SARS-CoV-2 infection or COVID-19 is being made by recoding the capsid, the structural genes, thousands and thousands of second and third base codon changes, which do not alter the amino acid sequence, but which alter the RNA sequence, and that's sufficient to attenuate. And it's unlikely that those thousands of changes will revert in humans. So that's the one I understand is being developed. Yeah.
There's Merck is, I think, also working on an attenuated vaccine. And I don't have my notes handy from the conference call, or I'm not even sure they went into details about the technology. But in modern with modern molecular tools, it is possible to take all this into account and design your attenuated vaccine so that the chance of reversion is just basically off the table.
Polio vaccine, being one of the very first that was effective, besides yellow fever, served as a model for the future of the development of vaccines. So, Vincent, you are sitting in a very historical chair right now.
No, the yellow fever vaccine was the first attenuated vaccine. So that really was
it's never reverted back to its wild type.
No, it has more changes than the polio vaccine.
But that was by serial transfer, wasn't it?
Yeah, so Max
Yeah,
Tyler passed it over 100 times in suckling mice, and
Sure.
it became and that was the only. He got a Nobel Prize for that. So
Yes.
the only Nobel Prize for a vaccine. Max Tyler.
I believe it's true that all of the attenuated vaccines that are currently licensed are vaccines that were made by this empirical process of serially passaging virus either in culture or in eggs or back and forth and hoping out the other end that you got something. I mean, the way I think about this is
out
that
the other end. Good.
You're passaging
in one end, out the other.
You're passaging the virus in the absence of all of the sort of immune pressure that it's ordinarily under, okay, and putting it through a whole different set of bottlenecks. And you hope that you come out with something that still grows sufficiently so that you can grow up a stock of it, and grows sufficiently in a person so that you get all the viral proteins presented, but then otherwise doesn't cause disease. Nowadays, I don't know if anybody's doing that anymore, but certainly we have the capability, and it's being applied in many cases, to take a much more strategic approach using genetic engineering to engineer viruses that are crippled with respect to pathogenicity.
Isn't that so? MedImmune's flu mist is engineered, isn't it?
MedImmune's flu mist, yes, is engineered. So the background
the backbone
is a virus that's temperature sensitive,
and cold
adapted.
adapted.
Out of a temperature sensitive mutant collection.
Right.
Cold adapted, and temperature sensitive.
Adapted.
So that's the backbone.
And what they do is they take the hemagglutinin and neuraminidase from the currently circulating flu strains and reincorporate that into that otherwise attenuated backbone.
But that's how they have always done the flu vaccines. But there's a new dengue vaccine in trial, TWiV 1 or 3.
Whatever.
The 3', they have a 30 base deletion in the 3' non-coding region, and that attenuates the virus. And so that will likely get licensed because it seems to be better than Vaxia. That's being developed through NIH and others. Rich, can you take Perry, please?
Perry writes, "Hi, TWiV. Hello from a colder 13C here in Sheffield, UK. You all won't believe that a UK government-sponsored SARS-CoV-2 human challenge trial has been proposed. Using controlled doses of virus, the aim of the research team will initially be to discover, this is in quotes, the smallest amount of virus it takes to cause COVID-19 infection in small groups of healthy young people aged between 18 and 30 who are at lowest risk of harm. Up to 90 volunteers who are compensated for the time they spend in the study could be involved at this stage. If approved by regulators and ethics committee, the studies would start in January with results expected by May 2021. He gives a link to the article. I recall your disapproval in doing human challenge for a novel virus. Please comment on this UK trial. Thank you. Keep up the good work. Best regards, Perry." We've talked about this before. Personally, I think it's a bad idea.
It is.
I think it's an even worse idea now than it would have been a few months ago.
Yeah, we don't need it anymore, right? We have plenty of cases.
Yeah, I mean, the whole reason to do this would be to accelerate vaccine development, which you could have done. You know, if back a few months ago, instead of going directly to phase 3 with Pfizer and Moderna et al., you'd done a challenge trial, you could have gotten very early efficacy data, but at a risk that I don't consider ethical, and that's a value judgment. Now, I mean, results expected by May 2021.
Yes.
May 2021. I mean, we're going to have results from probably at least 3 phase 3
for sure,
properly done phase 3 clinical trials with tens of thousands of participants. We don't need this anymore.
Yeah, I think this is a bad idea. And I also think looking at this design, a max of 90 volunteers, and remember, we're humans and we're an outbred population who have lots of differences and different doses to see what's the minimum dose. I kind of have a feeling they're going to get so much variation that they won't be able to interpret much. And so it's a bad idea. And I don't know that it's a good study either.
Yeah.
And remember, if they use this to license a vaccine, it could only be licensed in people 18 to 30 years of age.
Which is the people who least need it. Yeah.
Now, I looked
riffing
into
on Brianne's idea, if you proposed this in a grant, they'd probably tell you didn't have enough animals.
That's right.
Yes.
By the way, I looked at this article, and it turns out that after they infect these people, they're going to monitor them. And if anyone should become infected, they will immediately give them remdesivir. So tell me, how can you do a vaccine trial if you're going to treat everyone? I mean, they don't want them to die. That's why they're giving them remdesivir.
Yeah.
Now, maybe they're going to just do that for the dose response. They want to know how many PFU you need to give people to it. Okay, fine. But then when you do your real challenge trial, you can't give them remdesivir because that's the whole point of the challenge after vaccination. So this is on many levels ill thought out. It's not needed. It's not safe because, you know, if the death rate in this age group is 0.5%, one or two people could die in this trial.
You're going to kill somebody with this. Yeah.
And how are you going to explain it to their parents?
And even if they don't die, and they may not, no one may die, they may have long-term sequelae that
absolutely
interrupts the rest of their lives, basically.
That's right. Now,
yeah, so hey, Brits, you can save $33 million by not doing this study.
Plus the cost of the remdesivir.
You know, you can do challenges with influenza strains, and they do those in people who are vaccinated. You can use rhinoviruses, noroviruses, which don't kill people. Any virus that doesn't kill you, you can even do it. They did a challenge trial with a new polio vaccine, but in people who had been vaccinated against polio. But this, we don't have a vaccine. This is just wrong. And yesterday I got in a big argument with someone who said, well, an ethicist said this is okay. And I said, oh, what?
But another ethicist said it's not.
I know.
It's not okay. If you shop around, you can find an ethicist who will say just
you got it right. That's exactly right. As long as the honorarium is appropriate.
All right. One more email and then an image. And this email is a good question. I'm curious how you would respond. It's a good point. This is from Ben, who is a retired U.S. Air Force guy in California. Dear TWiV, during Daniel Griffin's clinical update from 673, Vincent asked if the increased cases in the U.S. and Europe were due in part to school reopening. Dr. Griffin conveyed what I understand to be the current state of the evidence, namely that the precautions schools are taking appear to be effective and schools are not driving increased cases in their communities. Well, no. They're not in, yes, school infections are not, but the communities, as someone else said earlier, are driving it. Of course, new evidence could emerge tomorrow and change my understanding, but for some reason, Dr. Griffin was not content to stop where the evidence stopped. It seemed to me that he felt that one way or another, he had to get to the conclusion that schools were responsible, and if the evidence did not support it, he would find a way to get there. And thus, he suggested that reopened schools sent a message to the community that wider precautions could be relaxed and that this indirect effect was driving infections. My understanding, and indeed what Dr. Griffin and others on the podcast later said, is that virus spread is occurring not in the classroom, but during the students' social interactions outside of class. Meanwhile, places where spread is known to occur, for example, restaurants, bars, and coffee shops, are largely open, albeit with restrictions like outdoor seating, capacity limits, and masks. But they're open. And schools in many parts of the country, including here in California, are closed. This is causing significant harm that many others have enumerated better than I could. If those harms are necessary to control the pandemic, then so be it. But if they're not, let's not continue them. I'm not suggesting Dr. Griffin's hypothesis is unreasonable, but I do think it's just that, an hypothesis. And if it's supposed to be an argument to keep schools closed, I think it's a poor one. Consider another hypothesis. While anti-racism protests in the spring didn't directly lead to outbreaks in the cities where they occurred, they sent a message to the community that lockdowns and other precautions didn't need to be followed if it was for something you felt was important. And this led to increased cases through the summer. Good argument? Alan, I think you might have thoughts about this.
Yeah. So good point about schools. Going into it, we didn't know, right? This summer, when we were talking about should schools reopen, we've got so little data to go on with this virus. We didn't even have it. We had schools closed last year in March, and we hadn't had anybody back in school since then. What do we do? And so I think pretty much everybody in public health went with what we know about every other damn respiratory virus in existence, which is the schools are where it spreads, right? Mm-hmm. I mean, that's where your flu goes. That's where your seasonal coronaviruses go. That's if you're a parent, you know this, you send your kid to school and they come home and you come down with a cold, everything spreads through the schools. Why wouldn't this? And so the proposal was, well, okay, if we distance them, if we put up barricades here and there, if we disinfect, if everybody's in masks, if we only have half the students show up, but nobody knew if any of that was going to work. Right. So going in, I think it was totally appropriate to say, we've got to be very slow to open schools. We need to start with virtual school. We need to let some students in, see what happens. Now the evidence is accumulating that with all these precautions in place, with reduced population of students in the school, so we maintain the distance with the masks, with the, all the procedures, schools may not be driving the resurgence. We are indeed seeing a second wave in most states now, even in states that responded well. It does coincide with the reopening of schools, but it also coincides with the reopening of a bunch of other things. So in Massachusetts now, we started indoor dining. Well, I say I'm certainly not doing it, but they now allow indoor dining in a lot of restaurants if your town is in the green or yellow zone. We've got data showing that's a bad idea, right? The data don't really show that the schools are a bad idea, but they show the restaurants are a bad idea. I think maybe we do need to take a more nuanced approach to this and say, maybe if your case counts are low enough in the community, reopening the school can be done in phases.
I think that's the key.
When your case counts come up, you may want to close the school as part of your across the board response, but you need to close other things too. You should not have indoor dining in restaurants and schools closed. Right?
Yeah, that's for sure.
You're not hitting the big problem.
I think the community numbers are important, as you say.
Community numbers are vital to this.
Because if they get above a certain, and you have to be testing in the schools, because then if you test and you get a certain number of cases, you have to close. And that's part of all the plans. Now, here in New York City, the schools opened later, but they are restricted. They are much reduced classes. If you can alternate students coming in, that seems to make a distance on top of distancing. But as Alan said, it's an experiment. We didn't know back then. And I don't know what California is doing, actually. Are they really closed, or they're all online, or do we know?
I
don't know. Yeah, I think that point about the fact that we haven't tried this for anything else before in terms of infectious disease in schools is an important point. And I also think that we should think a little bit again, back to something we said a long time ago about thinking about spread in our communities and not just our own risk, and think about, balancing for our community. If we're going to only have one open, should we have the school or the bar open?
The answer is yes.
Yes. If you can have this level of nuance, we're going to have to understand that maybe for this virus, and given appropriate precautions and low enough spread in the community, the school should open before the bar. People might say, well, if the schools are open, you better open the bars. But no, I think in terms of risk, and again, it's nothing against bars personally, It's just this virus spreads in that environment.
That's right.
I will go to your bar when you reopen it.
Yes, exactly. And I will absolutely go to your restaurants when you reopen them. I miss going out to a nice restaurant meal with my family.
Me too.
But you can't render it safe because people have to take off the mask to eat. They're talking. That's part of the whole restaurant experience.
Of course.
In the schools, you can mask everybody up. You can have them all facing in the same direction. You can, do all sorts of things to limit spread. So it's just a question of reopening things that can be rendered safe. And now we're getting the data about schools and we're saying, yeah, there probably are safe ways to partially reopen schools.
Yes. And I think we should also, note that there were some important problems happening with members of our community that were why we had those protests. So we should not discount those terrible things that were happening
I'll go a step
members
further.
Of our community.
I'll go a step further. It is your right to assemble and petition the government for a redress of grievances, and that is literally a hill I will die on. And if you are protesting for Black Lives Matter, or if you're protesting for I want to be allowed to go get a haircut, I don't care. You have the right to do that.
How about if you're protesting because I don't want to wear a mask? Is that allowed?
Fine. You can go protest that. And as it turns out, all of those, even the I don't want to wear a mask protest, were not that dangerous because they were outdoors.
Right.
People were moving around in ways where they didn't have prolonged contact with each other. So yeah, you can have safe protests, and that can be done, and regardless of the cause.
It's a different
whether I agree
situation
with it or not.
So they've actually opened up a lot of sporting events the same way. You get a limited amount of people, but when you've got 20,000 people sitting in an arena looking at a baseball or football game, it's risky. There's no question about it. It's risky.
Well, the U.S. Open just happened and was a wonderful success, and you missed some great tennis if you didn't see it.
You're right. The NBA finals are good.
I think team sports are having a lot more problems. So I know there have been issues with some football teams and some baseball teams where you've got everybody in the locker room, and okay, those are going to have to be doing a lot more testing, and that's going to be a much harder situation to deal with. Right. Tennis has the advantage that you're 100 feet away from the other person, and the judge is up on a chair, and they were able to do the whole U.S. Open without a big spreader event, but it was surreal because the stands were empty. And they put canvas covers on them to absorb the sound as if there were people in the stands.
That's right.
Somebody would hit some amazing shot and it's just quiet. It's the U.S. Open. And you see that. And so it is different, but there is stuff that we can safely reopen. And I think, we should revisit the issue of school reopening in terms of all of the data.
So
one of the things that go ahead, Vincent.
No, you've been wanting to talk.
Yeah, we've interrupted you too many times, Rich.
One of the things that I see in this letter is that such and such a behavior or event, quote, sends a message to the community, unquote, that this or that. So I'm thinking to myself, what is the medium here for the message? We talking internet? We talking gossip, okay? And I go back to our conversation from earlier, and that is that there needs to be a science-driven, studied message that comes from a reliable central source, okay? That all of these situations, we have to understand that it's an evolving situation.
Exactly
all of these different venues and activities need to be evaluated, okay? And then put together in the appropriate message communicated from a reliable source, rather than mixed messages coming out and everybody running around trying to figure out for themselves what's going on.
Yeah.
Maybe that's why Sweden did what it did. It's possible because you give one message, okay, everybody does the same thing. Unfortunately, it was the wrong thing, but everybody did it. So, and you get a country like Japan where they said, if you don't wear a face mask, you're going to die. Okay, fine. They've been doing that for years anyway. So it really fit into their culture, I think. But school's tougher. What about bartender school? Just to throw that into the mix. Throw it into the mix, so to speak.
You set mannequins at the bar and you paste their order on their forehead on a post-it, and you don't have actual people in the bar.
No, you don't.
Just the student.
Anyway, I mean, Ben made good points, and
yes,
I'm glad that Ben made them in a calm way without trashing us and saying that we're liberals or something. Okay, because a lot of people like to do that, and thank you, Ben, for doing that. And just one more email from Sonrisa, who sent a photo of a billboard in New York City.
You gonna read this?
No, I will not. It's
you can read the billboard, but not the hashtag.
Yeah,
it's a picture of a mask on the side of a building. Notice, masks save Democratic and Republican lives. And then there's a hashtag, wear an effing mask. Kenneth Cole sponsored this. But if you look carefully, someone has penciled in a different hashtag above the one that's on the actual post, and it's hashtag brainwashing. So it's someone who thinks wearing a mask is brainwashing. There we go.
Brainwashing.
All right. Let's do some picks of the week.
Sure.
Dixon Despomier.
Yes, sir.
Is it that time of year?
Well, my pick is an easy one. I love October for two reasons. One is that, three reasons, actually. One is that usually the World Series is being played during that month. Always the Nobel Prize winners in various categories are announced. But the one I love the most of all of them is the winners of the Nikon Small World Contest. And this year's winners were posted very recently, like 3 days ago or 4 days ago. And some of these images are startling.
Yeah.
The technology has advanced so much in the last 5 years. These layered, in focus, three-dimensional visualizations of a zebrafish's lymphatic system, for instance, using fluorescent proteins to light them up. It's just, I must harken back to the reason why I really like this contest is because in 1976, I supplied the material that won the first prize. It was a nurse cell. And if you look at the winner in 1976, it was Eric Gravet. He was a medical photographer at Columbia University. I gave him the sample. He took it home. He manipulated it in such a wonderful, beautiful way. It was a phase contrast interference photograph of the nurse cell, which we now use in our TWiV cups, by the way. And so I've followed this thing ever since. And
nice.
It's fabulous, just fabulous. In fact, there's even a parasite. There's a couple of parasites in there, but there's one of a head louse that's just remarkable.
Nice.
It puts new meaning to the word itchy scalp.
I think my favorite may be the Bogong moth.
Oh,
okay. It's just so the detail.
Yeah, exactly.
Not just in the picture, but in nature is just astonishing.
It lets you see the true beauty of evolution.
It's great. Yeah,
this is
really
the true
great.
beauty of
It's
evolution,
beautiful.
as far as I'm concerned.
Lovely. Thank you, Dixon. Brianne, what do you have for us?
I have something that is based off of our earlier conversation about herd immunity. It's something that I use to talk about herd immunity with my students. It's from a group at the University of Pittsburgh called FRED, the Framework for Reconstructing Epidemiological Dynamics. And this actually shows what will happen in terms of spread of particular infectious disease in an area based on the percent of people who have a measles vaccine. So it assumes one measles case in a particular area and shows how measles spread can be blocked based on different numbers of people being vaccinated. You can certainly see that the differences are not just in the difference of people who have been vaccinated. We can get to some of those things we saw earlier about preventing spread to those who are unvaccinated. And this actually takes into account real data on things like population density. So you can put in your state and a city And you can actually watch a measles epidemic happen at both 80% vaccine rate and 95% vaccine rate. I use this in class for the nearest city to Drew, and it always makes the point much better than I ever could make verbally to any of my students. They always sort of really have a lot of impressive thoughts about herd immunity when they watch this simulator.
Okay, cool.
This is great.
Yeah, this is beautiful, Brianne. I'm just doing Travis County here in Austin. It's very dramatic.
Very nice. Yeah, we'll have to use this in virology next year. Great.
Yeah.
Alan, what do you have for us?
This has been in my pick list for ages. But with people spending a lot of time at home, I'm thinking more about good books, and this is a really good book to just curl up with and dive into. It's Terry Pratchett's Small Gods. This is set in his Discworld universe, but you don't have to know anything about any of the other books or characters in Discworld. It takes place 1,000 years before any of the other events in the series. And it's Terry Pratchett's thoughts about religion, which are really interesting. So it's told from the perspective of a down on his luck God who he's down on his luck because in the Discworld, the power of a god is derived from how many people believe in him. and Ohm only has one believer left, which is weird because the Omnian Church, which is this huge organization, has millions of people under its purview, and they're this theocracy that's patterned on an organization you may recognize from the actual Middle Ages history. But it turns out that those millions of people don't really believe in the God; they believe in the church. So
this is plenty weird.
It is
good.
It is plenty weird, and it is a lot of fun. And it's Terry Pratchett he can be hilarious, and he's got some funny stuff in here. But this is mostly his serious book, and he really has some interesting things to say here, and he does it in a very good way. It's one of the best books I've ever read.
It says here, I think J.R. Tolkien with a sharper, more satiric edge.
Yes.
I've never read anything by him.
It's if you haven't read any Pratchett, this is a great place to start.
Okay.
I have more recommendations if you get into it, but
okay. Rich, what do you have for us?
I have a podcast called Boundless Body Radio, which is produced by a couple named Bethany and Casey Ruff, who are personal trainers in Salt Lake City. And their story is that they were both working at a chain mega fitness thing, and the pandemic got them dumped. And so good on them. They started up their own online fitness thing. They're both personal trainers, so they can do that. And they started up this podcast as well. I know about it because they're TWiV fans. And they contacted me and asked me if I'd do an interview. And so it's about health, basically, both mental and physical health. But it's all sorts of other things as well, because some of their other interviews include interviews with a professional basketball player, which is quite interesting, and interviews with a yoga guy, and interviews with another fitness trainer. So it's interesting, and I wanted to give them a little TWiV bump because I really respect what they're doing. These are the conversations that we used to have when we stayed up all night in the dorms when we were in college, okay, and solve the problems of the world. So
nice.
Listen in.
I hear enough of you, Condit.
I know. So you don't have
I'll listen to the other ones.
Yeah, listen to the other ones.
My pick is a book I read as a kid. It's a kid's book, The 21 Balloons by William Penn Dubois. It was written in 1947. And when I was in, I think, 7th or 8th grade, or maybe less, we used to have a library period where the whole class would go to the library and you pull books out, check them out. Yeah. And I remember the librarian, who was a nerdy guy, but he was a good guy. he said, "You want a suggestion?"
Andy was
Vincent?
a good guy.
He said, "You should read this, The 21 Balloons." And I checked it out and I read it and I loved it. It's illustrated. It's about this guy who takes a balloon trip out of San Francisco and a bird runs through it at one point and it falls. And I just remember that picture of the hole in the top of the balloon with a few feathers floating above it, to illustrate that. And he lands on Krakatoa. And there is a community of very wealthy people who welcome him and so forth. And Krakatoa explodes basically. So they all leave on a big platform that's held up by 21 balloons. And eventually this is the story of that. And I just remember the illustrations were so great. And I read it and that was the end of it. And then many years later, I was at a flea market somewhere and I saw it for 10 cents and I bought it. And it's on my shelf. And when we were doing TWiV on Wednesday, I was sitting next to the bookshelf. I had pulled out my virology book. And I said, up there is the 21 balloons. I have to talk about it sometime. So I read this from time to time. It's wonderful. And
Cool.
The illustrations are great. It's a kid's book, but I still love it. It's really a great story. And so I was reminded of it again. So check it out. It's
cool.
It's really cool. The illustrations are great. All right, that'll be it for TWiV 675, microbe.tv/TWiV for the show notes. If you want to send us questions and comments, TWiV@microbe.tv. And if you like what we do, consider supporting us. You are our main means of support. Microbe.tv/contribute. Or this month, of course, you go to parasiteswithoutborders.com and they will match your donation. So give them $20. They'll add 20 and give us back 40. That's a good deal for October, November.
It's a money amplifier.
It's a money amplifier. Dixon Despommiers at trichinella.org, thelivingliver.com. Thank you, Dixon. Muted. You're muted.
You're muted, Dixon. Come on, you got to do your sign off here, dude.
You're welcome, Vincent. You're welcome.
I did a conference with a Google guy a couple of weeks ago, and he had a T-shirt on that said, "You're muted."
That's good.
You should follow up with another T-shirt and says you're mutated.
He said, "Yeah, that's right." He said, "Everyone, I'm always saying this to everyone, so I thought I'd put it on a T-shirt." By the way, Larson, the cartoonist Larson,
Gary
Larson.
Yeah,
he had a cartoon of, and it was the title was something at parties, and there was a party with all these bacteria, and one of them was getting weird, and the other one said, "Look, Vinny's mutating."
Vinny's mutating. Yes.
He was good. I
Yes.
miss him.
Brianne Barker is at Drew University on Twitter, Bioprof Barker. Thank you, Brianne.
Thanks. It was great to be here.
Rich Conda is an emeritus professor at the University of Florida, Gainesville. He is currently in Austin, Texas. Thank you, Rich.
Sure enough, always a good time.
And Alan Dove is at alandove.com on the Twitter, Alan Dove. Thank you, Alan.
Thank you. It's always a pleasure.
I'm Vincent Racaniello. You can find me at virology.blog. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.